Good morning.
Good morning.
Good
Good
morning.
You
morning.
guys hear me?
Good
Yep, good
morning.
morning.
Hello?
We can hear you, Professor.
All right. It was my end. I couldn't hear you.
Good morning.
Good morning. I can hear you now. Okay. And we got the recorder going so we could get started here. I'm going to start where we left off. And actually, I'm just going to start a slide or two before that. All right. So these two terms you have to know. All right. So aphasia is inability to comprehend or express the language. And there's three main types: expressive, receptive, global. You have to know those three. So receptive is going to be Wernicke's, expressive is going to be Broca's, and global is going to be both. And dysarthria is when your muscles don't work well in order for you to produce the speech. So that can be caused by a number of conditions like Lou Gehrig's disease, or you might know that as ALS. There's some other diseases that could affect that as well. So anytime you have any sort of weakening in that area where those muscles are, where the speech is produced, it could affect the ability to produce that speech. So make sure you know those things, okay? Now, one thing I did want to clarify because in class, there were two questions asked. One was asked about just normal developmental delays with speech with children, and the other one was asked about autism, okay? So I just wanted to clarify because I said that this type of damage is not, it's not damage to this area that causes that, okay? But it is the connection. So if they don't, if this area is not making the right electrical connection, but it's not necessarily always here, it could be other areas in the brain that are not making the connections. Okay, so I just wanted to clarify that if someone had autism or a speech delay as a young child, there are multiple things that could affect it. We wouldn't expect typically damage to be here. But if the electrical connections or the other connections in the brain aren't working, like the Broca area to wherever that speech is being produced isn't working, there's a broken connection there somewhere, then they would have these issues in related to that area. But it's not just that area, there's a combination of factors affecting that. Okay, so expressive or motor aphasia is inability to speak. And so that's why it would be called motor. But when your question comes, it's going to ask about expressive, not motor. All right, but you have to understand that expressive is the ability to speak. So that's the muscles that produce that motor ability. But that electrical connection has to stimulate. So Broca has to stimulate that motor response and allow you to speak or write. Okay, so this is impaired ability to speak or write. That is Broca. Broca is in the frontal lobe. So if that's damaged, it's going to impair your ability or someone's ability. Typically, we'll see this with someone that's had a stroke or some sort of brain injury. Receptive or sensory aphasia, this is inability to read or understand the language. Okay, so you can speak it, you can say it, but you don't understand it, you don't comprehend it. So you're not able to process the information in the brain. That is Wernicke's area in the left temporal lobe. All right. And it usually also can affect your expression. Now, if both of these aren't working, then you have global. So if Broca's broken and Wernicke's broken, then you're going to have global. And these people typically cannot speak. All right, so it's a combination of expressive and receptive. This is major damage to the brain. So damage to Broca, damage to Wernicke, and to those communicating fibers or those nerve connections. Okay, those neurons got to be connected electrically in order to stimulate the reactions in the body that are occurring. So if there's some sort of disconnect there, that's not going to happen. That's what it's talking about with the communicating fibers. Fluent and non-fluent, influent aphasia, we're talking about the pace of the speech. So if you've ever heard someone that has psychiatric issues, sometimes their speech is really fast, especially if they're manic. And I mean really fast. Okay, you can barely keep up with them and they don't get tired. They just keep going, 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 going. And this can include made up words. This is damage also to the Wernicke's area. And then non-fluent is going to be slow, labored speech with short phases. Small words are sometimes omitted, and this is associated with damage to the Broca area. Dysarthria, this is where the words cannot be articulated clearly. So again, this is motor dysfunction, cranial nerve damage, muscle impairment. We'll definitely see this in someone with Lou Gehrig's disease as the disease progresses, because it continues to do both neurological and muscular damage. Agraphia is impaired writing ability. Alexia is impaired reading ability. So that's why, you can't read the remote or you can't read what you're supposed to do. You can ask Alexa to do it for you by just speaking it, right? Alexa, turn on the TV. And agnosia is something that you should see in long-term care.
TV
This
is
is,
on.
I'm sorry,
Yeah, but TV is on. You just turn it on.
say it again.
You just turned my TV on with Alexa.
Oh, I just turned your TV on. So you see there, you don't need much skill. Alexa responds quickly, right? Sometimes even when you're sitting in a room with someone talking, that Alexa or whatever will pick it up and start doing something on your phone. You didn't even tell your phone to do anything, but it automatically picks it up because of the human language and the way that the computer is programmed. So they're trying to program the computer to act like the brain. Agnosia is loss of recognition or association. So when you talk about association, like they're not associating what the item is that it was previously used for. So you'll see this especially on your memory care units. Okay, your clients will be giving something for their ADLs, and you're trying to help them do their ADLs in the morning. Now, you're not supposed to do them for them, right? So you hand them the toothbrush, and they start brushing their hair with it because they don't recognize that it's a toothbrush. They're not trying to be funny. They absolutely do not recognize that it's a toothbrush. You might see them do this with people. People will come into the room and they'll call the people other people or speak to them as if they're someone else. And that's who they physically see and recognize is that other person, not the one that's standing there. And so sometimes families will be extremely upset because they come to visit their grandmom and their grandmom has no idea who they are. Now, seizures, we talked about this a little bit when I was talking about the firing of the neurons in the brain. So, a seizure is caused by spontaneous or excessive discharge of neurons in the brain. It's electrical activity. Things that can cause seizures are things like inflammation, hypoxia, bleeding in the brain, but other things can lead to it. Like back in the day, a lot of your seizure patients, they would routinely give them suppositories every 3 days, and some places still do because they believe that the constipation would stimulate the vagus nerve and stimulate things in the body and cause that seizure to happen. So, other things that could cause this is fevers. So, in young children, they can have febrile seizures, but they're a little bit different because these seizures here are being caused by something abnormal in the brain, whereas the high temperature in the children, usually those types of seizures go away. But if someone has like regular seizures, like epilepsy type of seizures, that's not typically going to go away. They'll usually end up being on some sort of medication for a lifetime. Not saying that it couldn't, or if we had some sort of brain surgery, maybe it could stop it. And there's certain things that they do now. They'll remove parts of the brain, and they do a lot of different things to try to stop the seizures. And they're using a lot of different sorts of new treatments to try to stop this now. But your main causes are going to be inflammation in the brain, which fever could induce, okay? Hypoxia or bleeding. And again, bleeding in the brain is going to put extra fluid in the brain where it doesn't belong. The brain can only hold so much fluid, and that blood will irritate the tissue in the brain because it's not supposed to be in there. Now, focal seizures are going to be at that particular site of the irritation. So, wherever in the brain is irritated, that's where that seizure is occurring. It can become generalized and affect other parts of the brain. Other things that you'll see here is an aura. So, an aura is something usually that a client will feel before the seizure occurs. So, they may have a particular smell, they might feel a certain way in their body. And so, when that aura starts to occur, they kind of realize that they're about to have a seizure. But it doesn't really mean they can do anything or control anything about it. They just realize it's about to happen. Now, new technology has things out there called vagal nerve stimulators. I don't know if you guys are familiar with them or not, but the vagal nerve stimulator is something like a magnet, and you can run it across. They'll have in their body, they'll have implanted device, and that device is going to affect that vagal nerve. So what would happen is we would take that magnet and run it across the area where that device is, and it will trigger that vagal nerve to stop the seizure. That's the intent of it. So if a client does have an aura, then they could go ahead and try to swipe that magnet if they're cognitive, or even a staff member could swipe that magnet for them and potentially prevent the seizure from happening. If you have money or really good insurance, they have now automatic ones that clients can wear on their wrists. And these automatic ones supposedly can recognize the aura in the client and go ahead and start to stimulate that vagal nerve to stop that seizure or that convulsion. So remember, it's that electronic, those excessive electronic activity by the firing of those excessive neurons. Generalized seizures will involve all areas of the brain, and they do this from the time that they start. You have absence seizures. These are known before as petit mal. Absence seizures cause someone to stare into space. So usually you don't even know this is going on with the client. You're doing something, you look up, something prompts you to look up and look at the client, and you notice that they're staring into space. Sometimes before they do this, they'll have like little body movements, like eye blinking or lip smacking. Again, that could be part of their aura as well. And then tonic-clonic seizures, these used to be known as grand mal seizures. So tonic-clonic are really the worst, other than status epilepticus, okay? Which a lot of times these tonic-clonic seizures will lead to. But the tonic-clonic seizure is going to be the most dramatic type. We'll have loss of consciousness, stiffening, shaking of the body. People can urinate on themselves, bite their tongue. And again, they can go into status epilepticus, which is a medical emergency. And this is when they have back-to-back seizures, usually three, or if it's longer than 5 minutes. If it's a first-time seizure or a seizure in someone that's pregnant. Those are the ones you really got to be cautious of. And then myoclonic seizures, these will be like a sudden brief jerking or twitching of the arms and the legs, but they don't lose any consciousness there. Partial seizures are the same as focal. Okay, so they only involve one part of the brain. And again, it's just going to cause a problem in that area there, but remember that it could turn into a generalized seizure, which would affect all or multiple parts of the brain. So, status epilepticus is when that seizure is greater than 5 minutes or you have multiple seizures back to back. Most places you work at have a policy, and it's usually three or more because a lot of times clients will have two and they'll have an order in place for you to give them something to stop the seizure. Increased cranial pressure. So this happens whenever there's any sort of inflammation or sometimes infections in the brain. This can come from a brain injury. And what happens is the brain is really rigid. Okay, it can't expand. So any blood, fluid, cerebral spinal fluid that's in there, it's not compressible. There's nowhere for it to go. And if you put the pressure on there, it could cause a brain hemorrhage. It could cause the brain stem to blow out. Okay, so there's no room for that fluid, and mostly because of the bony, rigid makeup of the brain. So what we'll have is an increase in fluid, or this could be caused by some sort of like brain tumor, which causes an increase in the pressure in the brain. So the skull should only have brain tissue, blood, cerebral spinal fluid, and the volume each must stay constant. That causes that normal pressure in the brain. There's little fluctuations that can occur with the blood flow and the blood pressure, like when you cough or you bend over. Okay. But other than that, we can't really have anything extra in there because of the way that the skull is created. So the result is when we don't have the normal stuff that we're supposed to have in the brain, okay, it can cause high pressure and eventually the brain tissue itself will become compressed. The function of the neurons and the brain tissue will die. The pressure will increase at the site of the problem initially, but then gradually is dispersed throughout the central nervous system by continuous flow of cerebrospinal fluid and blood, and this is going to cause widespread loss of function. Changes in increased cranial pressure are usually monitored by instruments that we stick into the brain. This is an invasive measure. We'll try to do it indirectly first. Obviously, we don't want to open up the brain and put the client at risk for infection, but sometimes we have no choice. Indirect measurements would be like x-ray or assessing the person's level of consciousness and their vital signs. So those are going to tell you a lot about how your client is and whether or not they have increased cranial pressure. So we'll see this in brain hemorrhages, in trauma, in cerebral edema, infection, tumors, or if we have too much cerebral spinal fluid for some reason in the brain. All right, so this is just showing you the brain and what could happen. And if you notice right there at the bottom, increased cranial pressure and possible herniations. So any sort of these tumors, okay, or herniations can cause a problem here. So what would we expect to see in the client? Okay. So first thing is decreasing level of consciousness. So remember the RAS, the reticular activating system. I said that's for what? What does the RAS do? The reticular activating system. Let's go, nurses. What's it do?
Arouse you.
It's arousal.
Okay, the RAS will arouse your ass, right? So we're going to have a problem here because we're going to have pressure on that brain stem or the cerebral cortex. And that's going to put pressure on the reticular activating system. And that's going to cause a decrease in the person's level of consciousness. They might call that a decrease in the level of consciousness, a decrease in the level of responsiveness. They might call it lethargy, a headache. And this is because too much fluid. So, too much fluid is going to cause those meninges that are protecting the brain or the walls of the large blood vessels to stretch. And that stretching is going to cause that headache. Your emetic center is there in the brain, in that medulla oblongata. All right. And emetic stands for what? Think about it. What's the word emesis?
Vomiting, nausea.
Vomiting. So that's your vomiting center. So if you have pressure on there, what's going to happen?
Gonna puke.
Exactly. And it's projectile puking, like in The Exorcist. Okay. So we'll call that projectile vomiting. Okay. And we only see this in two conditions typically. One is this, which is not induced by any sort of food. It's induced by the pressure on the emesis center in that medulla. Okay, medulla oblongata, that's where your brainstem is, right? The other place we would see this is when, and we'll talk about this when we get to GI, is if someone had a pyloric sphincter. Okay, because the pylorus allows the food to move from the stomach into the duodenum, and when that can't happen, it causes projectile vomiting. So you'll see that in little babies. Usually, you can see it in adults too, but mostly we see that in babies. We're going to see a change in the vital signs. Okay, so what kind of change? So we'll see an increase in the blood pressure. And this is because of something called Cushing's reflex. So the brain's not getting enough blood flow. We call that cerebral ischemia, right? Ischemia means we're not getting enough blood flow. So it's to the brain, so it's cerebral. Okay? So Cushing's reflex is the brain's not getting enough blood flow. So what happens when we have low flow in the body? The body says, "Hey, bro, we ain't got enough blood flow." So it's going to cause vasoconstriction and try to increase the blood flow to the brain. We'll also see an increase in the pulse pressure here. What's that? Got to know this, by the way. What's the pulse pressure? Somebody knows this, nurse. What is it?
Pressure between
Between the systolic and diastolic number.
Okay. The difference between systolic
difference.
and diastolic. So that is going to increase. That should be between 30 and 40. But it's going to change. It's going to go up. So that's how you're going to know. Is you're going to see that change. Instead of it being 30 to 40, it's going to go up. Now, because of the increase in the blood pressure, we're going to have a slow heart rate. And that's how you're going to have to read the question. So when you look at, if it tells you signs of increased cranial pressure, you need to know we have an increase in the blood pressure, an increase in the pulse pressure, a slow heart rate because of that increasing blood pressure. It's also going to affect the person's vision. Okay, so increased swelling of that cerebral spinal fluid is going to cause swelling around the optic disc. And that's going to cause something called papilla edema. And when we look in the eyes with the optometry tools, we can see it. Pupils can become fixed and dilated because of pressure on cranial nerve 3. So that's going to usually be after a little while, okay? That's not going to be the first response, but eventually that's going to happen. You also have to know early signs versus late signs, okay? So early signs are going to be that decreased level of consciousness. Look at what they say. Decreased level of consciousness, decreased responsiveness, or lethargy. It could be any one of those choices. Why does that occur?
Decreased level of consciousness is lethargy,
Why?
severe headache, caused by increased ICP and swelling.
No. Why? Not good enough. Why? Come on, we just said this. Why do we have it?
The lack of ischemia.
Okay, let's go back. What will arouse your ass?
The RAS system.
The RAS. And this is caused because the RAS has what? Where's the RAS? Where's the reticular activating system located?
Is it in the medulla?
Yes, in the medulla oblongata in the brainstem, right? So increased pressure is going to cause what to that brainstem?
It's going to cause the brain to swell.
It's going to cause pressure on that brainstem, and that's going to decrease the ability of that RAS to arouse your ass. Decrease pupillary responses. Why?
Pressure on the optic nerve.
Okay, papilla edema and swelling of that optic nerve from that increased pressure of the cerebral spinal fluid. Severe headache. Why? It says that right there on the slide, right? Stretching of those blood vessels. Vomiting. Why? What's also in the brainstem? If you want to remember this, you got to speak it into existence. If you're not getting what you want to get on those tests, you got to talk this into existence. That's why I'm trying to make you speak it. I already know it. You got to speak it into existence. Why the vomiting? Where's that emesis center? Come on.
Still in the
The
medulla. Still
medulla
in the
oblongata.
medulla.
In the medulla oblongata in the brainstem. And what's going to happen to the brainstem with ICP?
It compresses the
Yes,
brainstem.
increased pressure, compression. Good. Papilla edema. Why? Remember, increased cranial pressure, increased cerebral spinal fluid, causing swelling of that optic disc. Things you have to know. These are your early signs.
What was your question with the with why papilledema? That's what you were questioning.
Yes, because of the increased swelling of
Swelling.
that
Okay.
optic nerve, okay? That
Thank you.
increased cerebral spinal fluid. Oh. So when the increased cranial pressure goes up, or when we get that increased cranial pressure, the body's going to try to compensate by shifting more of the cerebral spinal fluid down to the spinal cavity and increase the venous return from the brain. This causes hypoxia, and that triggers vasodilation in the arteries in the brain. Now, your brain will produce local autoregulatory reflexes. So, this is something happening without your control to try to control and improve the blood supply going to the brain. that causes additional fluid in the skull, and it's only effective for a short period of time. ICP is often significantly elevated before we even see the signs. So the first indication is what? What's your
Change
first
in the level of
indication of
consciousness.
ICP? Say it again, Heather.
Consciousness. Level of
A
consciousness.
Decreased level of consciousness. And it occurs why?
from pressure on the RAS.
Okay, from pressure on the reticular activating system. Other signs, okay, are going to be a severe headache from stretching of the large blood vessels, vomiting, projectile vomiting. Why?
This is
Because
because of the
the
pressure
emetics,
Pressure on the medulla.
Okay, pressure on the emetic center in the medulla oblongata. Papilla edema, why?
because of increased swelling in the optic nerve.
Okay, increased pressure in the brain and increased swelling of the optic disc. Good. All right, so as the ICP continues to build, a sequence of events is going to occur in order for the brain to get the oxygen that it needs, because if it doesn't, what's going to happen? Brain cells are going to start to die. Okay? So we have cerebral ischemia. That's that Cushing's reflex. So that means the brain is not getting enough blood flow. Okay? And so the brain is now going to try to increase the arterial supply to the brain. The body's going to try to do this by trying to compensate. Let me get off this slide to the next one. All right, you see that development of cerebral ischemia. So that is blood flow to the brain. And your body is going to try to put yourself in homeostasis here by increasing the arterial blood flow to the brain, because the brain recognizes it's not getting enough blood flow, and the body recognizes that. So we call that Cushing's reflex. I would know that. Systemic vasoconstriction. So now the blood pressure is going to increase. We need more blood to the brain because of the ischemia. That's going to cause what to the heart rate?
Increase of
rate.
A decrease. So the heart rate is going to go down. They're going to have bradycardia here when this happens. In the carotid arteries, the increase in blood pressure and the slowing of the heart rate. That's how the baroreceptors are going to respond. All right, you also have those chemoreceptors. Remember, those are the first ones that respond to your ABGs. So now you have low carbon dioxide level, reduction of the respiratory rate, and the body wants to improve that cerebral circulation, relieve that ischemia. Okay, that'll happen for a short time. But then the increase in the cranial pressure will cause the ischemia to come back. And this cycle will repeat itself over and over. And as it does, the increased cranial pressure continues to rise if we don't remove the cause. The blood pressure is going to rise. Increase in the pulse pressure, which is what?
The difference between
Systolic and diastolic.
Okay, and normally that's what?
30 to 40%.
Okay, 30 to 40, about 30 to 40. So what does that mean? If my blood pressure was 120 over 80, what's the difference there between 120 and 80? It's 40, right? That's a normal blood pressure, right? And the pulse pressure there is what? 40.
40.
Right? So now let's say it increases. So now my systolic is 160, okay? My diastolic is still 80. So now what's my pulse pressure? 50.
80.
All right, so the brain responds to ischemia by a feedback control measure for blood pressure, while other mechanisms try to protect the rest of the body. And this causes a conflict of interest in the body. As the ICP rises, so does the systemic blood pressure. That increasing pulse pressure, that difference between the systolic and the diastolic, is important in people with ICP. This widening gap results from the slow heart rate and the intermittent rapid off and on Cushing's reflex that's controlling that vasoconstriction in the body. So it's a vicious cycle here. All right, what are we going to see? We're going to see an increase in the blood pressure and the pulse pressure, a decrease in the pulse or the heart rate, a decrease in respirations. So, in addition to papilla edema, other indicators of increasing intracranial pressure are seen in the eyes. Pressure on cranial nerve 3, which is the oculomotor nerve, will affect the size and the response of the pupils. So one pupil ipsilateral to the lesion becomes fixed or unresponsive to the light and dilated as the peripheral nervous system in the affected oculomotor nerves become unfunctional. We'll have additional pressure increase. So both pupils eventually will become fixed, dilated, or what we call blown. Other signs of increased cranial pressure are ptosis or droopy eyelids. This is another cause of pressure on that cranial nerve 3. And innervation to the muscle of the upper lid is impaired. So the body can't send that message to the eyelid to work the way it's supposed to. And this can cause abnormal or excessive movement of the eye, something known as nystagmus. So the eyes can move all over the place. Now, who can tell me what ipsilateral means?
Is that one-sided?
Same side, power
Okay.
lines.
Yeah, same-sided, okay? So make sure if you don't know what terms are that you look them up. Reason being because they may use those terms on the test. And if you don't know what they mean, how are you going to answer it? Same thing, I'm telling you, you better know, because if you don't know it, you won't be able to answer those questions on the test.
Once the pupils are blown, there's like no turning back, right? That's like an indication of brain death.
It could be an ominous sign.
Okay.
It could be if there is something they could do, and I would say normally possibly not.
Thank you.
But there's not an always in nursing and medicine, so. But usually certain signs are considered ominous that there's no turning back. And once those pupils become fixed, then they also won't have those doll's eyes reflex. You guys remember that? Doll's eye reflex we talked about?
Yes. Okay.
Usually the brain stem is blown out there. There have been some times when I've seen people with what looks like the eyes are fixed, but it's kind of a temporary condition. So I just want you to be aware of that. When we say always or never in nursing, we always want to consider, is there other potential causes that could make the eyes look fixed where they might not actually be fixed? But in this condition, more than likely the brainstem is going to be blown out here once those eyes become fixed, or there's an extreme amount of pressure, it's about to blow. So for cerebral spinal fluid, we also use that for a number of reasons. I would know that. I would know what it normally looks like. We usually get this from the lumbar puncture. Okay. And where did I say we could do that safely at?
L3, L4.
L3 of 4.
L3, L4. Okay. That can tell us what the pressure is in the brain. It can also tell us if there's some sort of infection, because if it's clear or cloudy, cloudy means we're going to take a better look at it. What should be in that cerebral spinal fluid?
Glucose, sodium.
Okay, how about red blood cells?
No.
No.
How about white blood cells?
Yes.
Yes.
How about protein?
Yes.
Yes.
Okay, what if there's too much protein? Probably a brain tumor. Okay, what if there's too many red blood cells?
A
Bleeding.
brain bleeder.
Okay, and what about white blood cells? Too many white blood cells.
Infection.
Okay, so if someone had like a basal skull fracture, we might see cerebral spinal fluid. Where would we see that at?
From the ear.
Coming from their ear.
Or sometimes their nose.
Nose.
Would we want them to blow their nose?
No.
No. And we could test it by putting a little like a 4x4 underneath there. And usually if it's cerebral spinal fluid, it'll produce what we call a halo or a concentric ring on that white 4x4. Also, we would test it for what? If we saw clear fluid coming out of someone's nose or ear after a head injury or a pituitary gland procedure, what would we test it for?
Those.
Glucose. Good. Okay. And then you see the yellow indication for infection, abnormal protein levels for a neoplasm, which is a tumor, red blood cells, head injury. So if a mass like a blood clot or a tumor becomes large enough, it can push the brain tissue down and displace it, causing a herniation. There's different types of herniations. We can have a transtentorial herniation, where the cerebral hemispheres, the diencephalon, and the midbrain are pushed downward, and that pressure would affect the blood flow of the brain, the cerebral spinal fluid. It would also affect, it would put pressure on the reticular activating system and on your respiratory system, because remember, that part of the brain also controls respiration. If we had a transtentorial hernia, if we had a uncal herniation, this occurs when the uncus of the temporal lobe is displaced downward past the tentorium cerebelli. This can put pressure on the third cranial nerve in the cerebral artery and the reticular activating system. So you can see both types of herniation would cause what? Both of them are going to affect your reticular activating system. So what's that going to do to you?
You're not
It's
gonna be
pressure.
awake and alert.
It's going to make you less awake and alert if there's pressure on your reticular activating system. So again, these are all the signs that we talked about, okay? Decreasing level of responsiveness, headache, nausea. Cushing's triad is that increased cranial pressure. So Cushing's triad is the increase in the blood pressure with a decrease in the heart rate And we're going to have a decrease in the respirations, and the respirations are going to be funky. They're not going to be normal. So sometimes it could cause Cheney-Stokes. And then we're going to have swelling of the optic nerve. Again, if you look at your progressive symptoms here, okay, when you were asking about the fixed pupils, look at your progressive symptoms here on the left. Lethargy, coma, and eventually death. Because when we're looking at someone on the coma scale, one of the things we are looking at are those eyeballs, right? How they're responding there. So this picture is just showing you the different types of herniation that we just talked about, okay? And how it's affecting or where it's putting that pressure at, so you can see what it looks like when it does that. Or where that pressure would be more really is what this is showing you, is where you would expect that to occur in the brain. I don't expect that they'll give you pictures, but you should know what's happening when that pressure is pushing down on the brainstem, okay? That pressure on the brainstem is what is causing the symptoms overall. It doesn't matter what the tumor is or where it's at, but different tumors would cause different pressure on the brainstem. So one tumor is going to cause a little bit different symptoms, or herniation is going to cause a little bit different symptoms versus another. We don't care about diagnostic tests. We already talked about the lumbar puncture. All right, next we're going to talk about brain tumors. These take up space in the brain, and so they cause increased cranial pressure, okay? Because remember, there's no place for any extra thing to be in that brain. Whether the tumor is benign or malignant, it can be life-threatening. If they're in an area that we can access, where they can be removed, then we might be in luck. But a lot of them are not in an area where we can easily do surgery and remove them or treat them. Gliomas are the largest category of primary malignant tumors. Malignant means it's going to affect you, right? And possibly kill you. But again, both of these can. Just because of the space that it's taking up in the brain. The gliomas, or the malignant tumors, they come from the glial cells, the parenchymal cells in the central nervous system, and they're called astrocytomas. These are the most common. Tumors that develop in the meninges or the pituitary gland can also cause neurological effects from pressure on the brain. Primary malignant tumors rarely metastasize outside of the central nervous system, but multiple tumors can occur within the central nervous system. Secondary brain tumors are common and usually metastasize from either the breast or the lung tumor, and they can cause effects similar to those of a primary brain tumor. Primary malignant tumors are mostly astrocytomas. And again, they don't have well-defined margins. We talked about this when we're talking about brain cells, about how brain cells are not well differentiated. So the margins look weird. They don't look anything like the other cells. They're invasive. They have irregular projections that can go into adjacent tissue, and they're hard to remove totally. Usually you're going to have inflammation around the tumor that causes additional pressure. Sometimes it can block the flow of the cerebral spinal fluid or of the venous sinuses and increase the cranial pressure there. If the mass expands, it can put compression on the tissue around it and eventually cause herniation of the brain. A small tumor in the brainstem or cerebellum can compress the medulla oblongata within a short time. Tumors in the cerebral hemisphere, especially in those silent areas that don't cause obvious symptoms, can grow quite large before we even notice them. So there's your astrocytoma. Those astrocytomas develop in the central nervous system. They grow from star-shaped astrocyte cells. They develop in the brain. And they can be either non-cancerous or benign, or cancerous and malignant. These are a type of glial cell. Glial cells provide supportive tissue in your brain. So some of the other glial cells in your brain are oligodendrocytes and epidermal cells. A glioma is a tumor that forms when the glial cell grows out of control. So you'll have normal glial cells, but when you have this astrocytoma or this tumor, then the glial cells are growing abnormally because of the cancerous DNA that's in them. It's already changed the normal DNA that's in the cell, and now it's reproducing with this tumorous or this cancerous cell. I think I skipped a page on yours. Let's go back. All right, so brainstem and cerebellar tumors are common in young kids, particularly if mom was exposed to carcinogens during the development. So most of that embryonic development is happening within that first 8 weeks. So let's say mom worked somewhere where she was exposed to something that would cause harm to the baby. During that time, this could cause these kids to develop these tumors. Tumors in adults usually happen during midlife, and adults are affected more frequently by tumors in the cerebral hemisphere. So the site of the tumor determines the focal signs. In some cases, focal or generalized seizures are the first sign because the tumor is going to irritate the surrounding tissue. If the tumor grows rapidly, then they'll develop increased cranial pressure, and that usually will start with morning headaches. So seizures, first sign, or morning headaches. The headaches will eventually increase in severity and frequency. Vomiting occurs. Why? Why vomiting?
Because the emetic center is in the medulla.
Okay, pressure on that emetic center. Lethargy and irritability. So why lethargy? What causes the lethargy or the decreased level of consciousness? Say it again, James.
Show on the rats.
Pressure on the rats, right? Pressure on the reticular activating system. And that can also cause changes in personality and behavioral changes. The brainstem or the cerebellar tumor can affect the cranial nerves. This can cause facial paralysis on one side, vision problems, focal or generalized seizures, again, may be the first sign due to irritation of the tissue around the tumor. If I'm saying it over and over, you better know it. And unlike other forms of cancer, brain tumors do not cause the usual systemic signs of malignancy because they do not metastasize outside of the central nervous system, and the person typically dies before the tumor is large enough to cause general effects in the body. All right, next we're going to talk about vascular disorders. So these are like your TIAs, your CVAs, your aneurysms. So these are usually caused because of coronary artery disease of some sort. All right. Vascular disorders can be hemorrhagic or ischemic in origin. If the deficit results from hemorrhage, then additional effects of ICP will cause ischemia and generalized symptoms. So what this is saying is if the stroke is caused by bleeding, okay, then we're going to see more increased cranial pressure. Why? Because blood is going to cause extra fluid to be in the brain. One. Two, that extra blood in the brain is going to cause irritation to the vessels in the brain because the blood's not supposed to be there. If the deficit is from hemorrhage, then we'll see increased cranial pressure and symptoms of increased cranial pressure. And that could cause ischemia, generalized symptoms. Global cerebral ischemia can develop because of either severe shock or cardiac arrest, impairing the perfusion to the brain, and that causes loss of function and generalized cerebral edema. So in mild cases, what will we see? Confusion, neurological dysfunction. If it lasts for a long period of time or if it's prolonged, then we'll have necrosis and infarction, and the person could go into a coma. So first we're going to talk about TIAs. These are temporary. So here we have a temporary reduction in blood flow getting to the brain. I expect them totally to ask you about this. Recovery from these happens in about 24 hours, and they're not permanent. So we have a temporary reduction in the blood flow. The problem is they are a precursor for a stroke. TIAs can be caused by partial occlusion of an artery, atherosclerosis, small emboli, a spasm in the vessel, or loss of autoregulation. So the body isn't doing its job. TIAs are a warning sign that a problem might be brewing, like a stroke or a CVA, cerebral vascular accident. The brain has to have glucose and oxygen. If it doesn't, it's going to suffer damage. All right, not everyone will have a TIA before a stroke. Some people just go right to the stroke. Signs of a TIA are directly related to wherever the ischemia occurred. The patient will remain conscious. They'll have short periods of impaired function, like muscle weakness in the arm or the leg, visual disturbances. Numbness and paresthesia can occur in the face. Transient aphasia or confusion can develop. The attack might last for a few minutes or longer, but usually never longer than 1 to 2 hours. Transient aphasia and confusion can develop. Repeated attacks are a warning of the development of obstruction related to atherosclerosis. So, atherosclerosis, you already know, is coronary artery disease. That's what it is. In the arteries and arterioles, blockage from things like plaque, sugar, and damage from years of eating too much fatty fried foods, from years of drinking excessive amounts of alcohol and stress, from years of high blood pressure ignored, and diabetes ignored. So all those things lead to this. A stroke or a CVA, cerebral vascular accident, is an infarction of the brain tissue where we're not getting enough blood flow. So necrosis can be an outcome of total occlusion of the blood vessel by either an atheroma or an embolus. Now, an atheroma is a piece of plaque, and it breaks off, and it flows, and it blocks the area. It can either partially block it or completely block it. And an embolus obviously would be a blood clot that breaks off and flows to that area. and this blocks or obstructs the vessel when it gets up there. Okay, so we don't get any blood flow there. We could also have a CVA because of a ruptured blood vessel. All right, one in the brain. And that would cause hemorrhage and increased cranial pressure. So remember, we talked about the circle of Willis. In that circle of Willis, where all those vessels come together, we call that, where two vessels come together, we call that a bifurcation. Okay? So just like the vessels in your body become weak, I say like the elastic in your underwear. That's what happens to the vessels. So remember, 5 years ago, you could buy Victoria's Secret underwear, or pre-COVID, you could get 5 pairs for $20, and those underwear lasted you forever, Victoria's Secret. Okay? Now you buy that Victoria's Secret underwear. I don't know what they did to the elastic, but you're lucky if you get a year out of it. It's not the same underwear it used to be pre-COVID. So your vessels are not going to be the same when you're young, when you get older, because of damage in the body from things that you eat and put in the body. The constant expansion and contraction wears the vessels out, as well as all that extra sugar flowing in there from high blood sugars, all the extra cholesterol. So think about your bacon grease when it's in the pan. When you're cooking it and it's hot, that bacon grease is all liquidy. But now you let the pan sit there for a couple of days, and what's it look like? That's what your arteries look like, because it might go in greasy and liquefied, but once it sits in those arteries, it's going to become hardened. And so the walls of the artery become less flexible, more rigid, more subject to damage. And it can be damaged from either blood sticking to the side of it, damaged to the tissues from inflammation, because remember, during inflammation, certain enzymes are released that can cause necrosis to the tissue. Okay, so all these things are doing damage to the body over time. It's a wear and tear on the body. Now, 5 minutes of ischemia causes irreversible damage to the cell. So necrosis will develop there, and inflammation, and function in the area is lost immediately. Now, remember, we were talking about liquid necrosis, and I said that occurs in the brain. So here, the brain tissue is going to liquefy, and it'll leave a cavity in the brain. Repeated attacks are a warning of the development of obstruction related to the atherosclerosis. So most of the time, these attacks are going to be caused by that atheroma, or that plaque breaking off and causing a problem. These attacks should be investigated, because eventually they could lead to permanent brain damage. This is just really showing you the process of what happens to the brain there. So you guys have this slide, you can take a look at it. So strokes are considered a major cause of disability. A CVA is infarction of the brain tissue that results from lack of blood. Tissue necrosis is usually going to be an outcome of ischemia, or the consequence of a ruptured vessel, which causes hemorrhage and increased cranial pressure. Atheromas develop in those large arteries like the carotid, and that causes narrowing of the artery by that plaque or a thrombus. And this can lead to either a TIA or eventually an infarction. Now, sudden obstruction caused by an embolus lodging in the cerebral artery is the second type of stroke. Emboli can result from materials like tumors, air, or infections. Like if someone had endocarditis, they could throw an emboli. Intracerebral hemorrhages are usually caused by ruptures of a cerebral artery in someone that has severe high blood pressure. That's the third class of stroke. Hemorrhagic strokes are usually more severe and destructive. They seem to affect larger areas of the brain. It's likely because we have a greater increase in the cranial pressure. with the hemorrhage. And so this can be complicated by effects of things like bleeding, disruption in the blood supply, free blood in those interstitial areas that are affecting the cell membrane themselves. And this can cause secondary damage like vasospasms, electrolyte imbalances, acidosis, and edema in the brain. So two main types of strokes are ischemic and hemorrhagic. Okay, and hemorrhagic is going to be a bleed, and ischemic is going to be a blockage. So risk factors or causes of strokes are going to be diabetes, high blood pressure, systemic lupus erythematosus, because remember, it can put those collagen deposits and cause problems in all of the organs. Atherosclerosis is going to be your major one there. And those atheromas, which is that plaque breaking off. History of TIAs, increasing age, obstructive sleep apnea, heart disease, smoking, sitting around on your booty too much, or that sedentary lifestyle. Oral contraceptives, mostly because of estrogen. Okay? Estrogen causes viscosity of the blood, and cigarette smoking does as well. It causes the blood to be really thick. And so those can both put you at risk for producing a clot. And then some sort of problem that you developed at birth, okay, to the blood vessels themselves. So the blood vessels aren't formed correctly or increasing age. All those are risk factors for strokes and causes. Okay, so warning signs, you want to be familiar with those. And then your signs and symptoms. Okay, so signs and symptoms depend on where the obstruction is, how large the artery is that is involved, and what functional area was affected. There are silent areas of the brain where dysfunction results from small infarctions and it's not obvious. Now, I was talking about that circle of Willis, okay? And I said that a bifurcation is where two of those arteries come together. That's where most of these are going to occur because the vessel is going to be a little bit weaker there. But also any vessel that could have been damaged because of the other issues that we just talked about. Obstruction of the small arteries, the person might not have obvious signs until they have several small infarctions. Sometimes the stroke can develop slowly over a period of hours. We call this an evolving stroke. Initially, flaccid paralysis is present. Spastic paralysis develops in the weeks later. Functional deficits can increase in the first 48 hours as inflammation develops at the site, and then sometimes it will subside as the neurons around the infarction start to recover. The NIH stroke scale is developed by the National Institutes of Health. You'll actually be taking this when you get into med-surg. I require all med-surg students to take that, and you'll get a 2-year certification, which you can actually get paid for when you go out to get a job after you graduate. This can help you make rapid decisions on the floor about what to do should you come across someone with a stroke. We also use the acronym FAST most of the time, okay? So we're looking at the face, the arms, certain things there. So look up that FAST acronym. That kind of tells you a little bit about the symptoms as well, and it might help you remember it. All right, so signs and symptoms, again, depend on the obstruction, the functional area, and how big the issue is as far as the obstruction or the bleed. All right, next is aneurysms, and these are caused by weaknesses in the wall of the artery. They can multiply Again, these are also going to happen at the points of bifurcation on the circle of Willis. We can have what we call a berry aneurysm, which is a dilation in the artery. Cerebral aneurysms frequently multiply and occur at these points of bifurcation. The berry aneurysms develop wherever there's a weakness in the arterial wall or where branching occurs. And here the blood at that point is being forced. Okay? And a lot of times it's aggravated by high blood pressure or hypertension. Sometimes the aneurysms are small and asymptomatic, but they can enlarge over the years. And you might know somebody that has an aneurysm, and the doctor might have said, no, we're not going to operate because it's too small, because insurance companies require that blockages in arteries and aneurysms be a certain size before we're allowed to do anything about it. Over the years, the aneurysm can enlarge and start to compress structures around it, like the cranial nerves, and that can cause either a rupture or clinical signs. Now, we'll see ruptures usually when there's a sudden increase in the blood pressure. This can be from exertion. The blood will go into the subarachnoid space and the cerebral spinal fluid, irritate the meninges, cause inflammation and irritation. The free blood causes vasospasms in the cerebral arteries. This causes additional issues with perfusion and more ischemia. Hemorrhage from the ruptured vessels causes increased cranial pressure and can lead to death. The enlarging aneurysm can put pressure on the surrounding structures, like the optic chiasm or at the cranial nerves, causing loss of vision. So that's why whenever someone has a sudden loss of vision, right, we're always going to look at that very carefully, because that's usually some sort of medical emergency. The enlarging aneurysm can put pressure on the surrounding tissues, the optic chiasm, the cranial nerves. The mass can also cause headache as tension increases on the blood vessel walls, meninges, headache, photophobia, which is increased sensitivity to the eyes with light, and intermittent periods of dysfunction. So this means the person might appear to be confused, they might have slurred speech or weakness, and sometimes we'll see a stiff neck, also known as nuchal rigidity. If there's a massive rupture or a subarachnoid hemorrhage, followed by an immediate severe blinding headache, vomiting, photophobia, seizure, or loss of consciousness, the person might actually die. So if you see those symptoms, that cerebral aneurysm is likely going to take them out. That's indicative of a rupture. So if a brain aneurysm is diagnosed before rupture, they could treat it surgically. At the interim, while the patient's waiting, that sudden increase in pressure could still occur. This is the berry aneurysm. So you see the bulging there where the red arrow is. Again, it's always going to happen in these weakened areas, usually at the bifurcation. Usually the beginning ones are going to be asymptomatic until it starts to compress the structures around it. And then you'll start to see the clinical signs. So pressure on the optic chiasm or the cranial nerves causes loss of the visual fields or disturbances in the visual visions. Mass or excessive bleeding can lead to the headache or tension on the blood vessels and the meninges. Leaks can cause headaches can cause things like headaches, photophobia, periods of dysfunction like confusion, slurred speech, weakness, and nuchorigidity will continue to develop as the blood irritates the spinal nerve roots and causes muscle contractions in the neck. All right, now we're going to talk about infections. So meningitis is one infection. This is usually caused by a virus, bacteria, or it could be from a fungus or parasite in the meninges. I don't know how many of you know Nurse Sarah. Anybody?
Yes.
Yes.
So she almost died from meningitis not too long ago. Did you guys know that?
Yes.
And it was called aseptic meningitis. And she believes she got bit by a mosquito or something in her garden. But this could also be caused by E. coli, okay, which we'll see usually in infants. Neisseria meningitis, which we usually see in children and young adults in the fall when they have those colds, okay, from those respiratory droplets. Late winter, early spring. We'll see meningitis a lot in schools or institutions because it's spread through the respiratory droplets. So when they're coughing, when they're sneezing, when they're talking, and they're in close contact with their classmates in college or in the school, that's when they're likely to spread it. So with the bacteria, it binds to the nasopharyngeal cells, crosses the mucosal barrier, and attaches to the choroid plexus. Remember, the choroid plexus is where we produce the spinal fluid. And the choroid plexus in the third and fourth ventricles. So if the bacteria goes there, then it's going to get into the spinal fluid and it's going to be spread all throughout the brain. So main things you have to know here is it's going to get in the spinal fluid, okay, because it's going to enter those nasopharyngeal cells, cross that mucosal barrier, and get into where the cerebral spinal fluid is. In children and young adults, it's going to be Neisseria meningitis spread by respiratory, those respiratory droplets. So coughing, sneezing, even talking. Happens more often late winter, early spring. For babies, E. coli. So common bacterial infections can lead to purulent exudate that covers the surface of the brain. It's usually going to get in that pia mater because remember that pia mater is right next to the brain and it has all those blood vessels there. The exudate is also present in the cerebral spinal fluid. Okay, and the blood vessels on the surface of the brain here will look dilated. Meningitis can be secondary to other infections like sinusitis or otitis because you can have a bacteria infection there and blow your nose too hard or the ears. They're all right next to the brain. So that bacteria can migrate there. It also can come from tooth infections like an abscessed tooth. Any sort of head trauma or surgery can lead to meningitis. Aseptic or viral meningitis can come from an infection like the mumps or the measles, or also from some sort of vector, like a tick or a mosquito. The microorganism in meningitis gets to the brain through the blood. It has access to the tissue, okay? The membranes around the central nervous system and the cerebral spinal fluid, which is where? Where's that cerebral spinal fluid located at? Got to know that for the test. Where's it at? Where's it flowing?
The subarachnoid.
Subarachnoid space. Okay? So it's flowing through that subarachnoid space. And it's getting into all the parts of the brain because that's flowing all around the brain. So the infection spreads rapidly through the coverings of the brain. Focal signs are absent because there's no mass of infection, but the inflammatory response causes an increase in cranial pressure. The pia and the arachnoid layers become edematous, and exudate will be present in the cerebral spinal fluid. So that means the spinal fluid is going to look like what?
Cloudy?
Cloudy. And the blood vessels are going to look dilated on the surface of the brain. With babies, look at that picture up there on the right. We'll see a petechial rash.
Sorry, question.
Yes.
You said the cerebral spinal fluid will look cloudy. Is this like on the regular or it's with meningitis? They'll look cloudy.
Which one?
The cerebral spinal fluid
You tell
will
me,
look
nurse.
cloudy.
When would it be cloudy? What does normal cerebral spinal fluid look like?
Clear.
Clear.
Clear. Clear.
Clear and liquid.
Okay, you're going to have to know that on the test. So look up your cerebral spinal fluid. You should know what's in it. We did this at the beginning of the slideshow. We talked about what cerebral spinal fluid should look like, what's in it, and what's not supposed to be in it. So make sure you go back and look at that. Okay? Because they
Okay.
are going to test you on that.
Okay.
Now,
Thank you.
for meningitis, they're showing you this slide, right? And they're saying neutrophils present, and it's bacterial. So, what do we say about neutrophils and bacteria? They go together, right?
Yes.
Wherever you have a bacterial infection, you're going to have a lot of neutrophils.
Got it.
All right. So, that's why your cerebral spinal fluid is going to be cloudy, okay, because of that bacteria in it. So other things it should have in it are glucose, trace amounts of protein, no red blood cells, one or two white blood cells. All right, so causes. We already went over this a little bit, but babies, okay, E. coli. And usually this is with a neurotube defect, like a myelomeningocele. Okay, so the baby has this rupture on the outside of their spine and they poop, and that diarrhea can get up in there where that neurotube defect is and get into the bloodstream. For most kids, it's caused by Haemophilus influenza in the autumn or the winter. And in children and young adults, Neisseria meningitidis. Older adults, it's going to be streptococcus. A lot of times they'll start with pneumonia. Okay. And because they're immunocompromised or something else is going on, they
Miss Loesch, you muted yourself.
signs and symptoms I expect them to test you on, okay? So it's going to be a sudden onset, typically, severe headache, back pain. They can't stand the light, so photophobia, stiff neck, which is that nuchal rigidity, Koenig's sign, I'll go over that in a second, and Brzezinski's sign. And then vomiting, irritability, lethargy, fever, chills. So with babies, I said they can have that petechial rash. Okay, they might have feeding problems, irritability, lethargy, a high-pitched cry. And remember, increased pressure in babies would be what? How would we see that? What's one of the things we look at to determine the hydration status in a baby? You're already nurses. You know this. So what is it?
Wet diapers.
Diapers.
Not diapers. I said one of the things we look at for increased cranial pressure that tell us about the hydration status. It wouldn't be a diaper.
Is it sunken eyes?
Say it again.
Sunken eyes?
So they might have sunken eyes. I'm talking about the fontanelles. You guys don't know about the fontanelles in a baby?
Yes.
Sinking
Sunken,
fontanelle.
sunken fontanelles, yeah.
What would they be sunken?
Yes.
They have increased cranial pressure?
No,
would be
it's not
both.
sunk.
It would be
It's
bulging.
Opposite.
Okay.
bulging,
And
yeah.
remember, babies also don't have what in their head yet? They don't have fusion of the bones. So they're going to have something called hydrocephalus, which means their head is going to look like a big balloon, like a cone head
In
almost,
water.
but it's round instead of being pointy. And they'll have something called sunset eyes. I think I might have a picture on here. I'm not sure. Potential complications are hydrocephalus if the cerebral spinal fluid is blocked, cranial nerve damage. The cerebral cortex may occur damage here, and this can result in developmental delays, seizures, and motor impairment. So this is your Kernix, okay? Where they lay on their back and you try to help them extend the knee, and it's very painful. And this is because the meninges in your brain go to your spinal cord, linked to your spinal cord, and your spinal cord runs all the way down your back. So it's very tight there because it's inflamed. And so when we move that movement there in your knee, it's extremely painful. That's Kernick. So Kernick is knee extension. I tried to give you a little tip there. And Brodzinski is when we flex the neck. Again, when you flex that neck, that spinal cord irritation is going to cause that pain. So Brodzinski, the neck flexion leads to the knee flexing. And the hip. All right, so we're going to look at that spinal fluid. All right, next is brain abscess. This is a localized infection that usually occurs in the frontal or the temporal lobes. There's usually necrosis of the brain tissue. And remember, I said necrosis of the brain tissue is going to be liquid usually. Okay? And it'll create like a crater or a hole there. And the area around it is going to be edematous. Abscesses usually come from organisms spreading from the ear, the throat, the lung, or sinuses. It can be from multiple septic emboli. So we might see this in someone who has sepsis who's going into what we call disseminated intravascular coagulation. Acute bacterial endocarditis from the site of the injury. And for these people, the signs, the focal signs, are going to be neurological deficits and the increased intracranial pressure. So common causes of this are staphylococcus, streptococcus, and pneumococci. This is just showing you a picture of an abscess in the brain. All right, encephalitis. You have to know this also. So know your disorders. This is infection of the parenchymal or connective tissue in the brain and the spinal cord. The necrosis and inflammation develop in the brain tissue. This can lead to permanent damage. Early signs are going to be severe headache, stiff neck, lethargy, vomiting, seizures, and fever. Encephalitis is usually viral. All right, Western equine. And how I remember this is Disney World. Okay? Why? Because Western equine encephalitis is usually spread by mosquitoes. It's more common in the summer and it's common in young children. So at Disney World, we have all that going on. You got that swampy land down there where there's lots of mosquitoes. Kids are there. Okay? When do most kids go to Disney World in the summer because they're out of school? So it's arboviral. That is what the infection is caused by. Now, St. Louis encephalitis, the only information your book gives on that is that it usually happens in older people. And I think about that with the way I associate that is because St. Louis is an old town in Midwest, in Missouri, and it's a really old town. So that just helps me remember this affects older people. It's usually more serious than that. Now, West Nile fever, I associate this with Flavor, my rapper Flavor. This is called by flavivirus, spread by mosquitoes. The host is a mosquito and a bird. I like Flavor. I got to see him on the beach last summer. Awesome concert. All right, so Flavor is West Nile, okay? And we do have this in New Jersey. So usually they'll recognize it because not of the mosquito, because it's a connection between a mosquito and a bird. So usually we'll find dead birds, a lot of dead birds laying around, and then they'll go ahead and do a study on the bird, and they'll discover that the bird has the flavivirus. So that one's going to cause flu-like symptoms, headaches. All right, Lyme disease. This is neuroborreliosis. This is Lyme disease, and this is a spirochete. So remember, spirochetes are those little curvy, cork-like bacteria. These are transmitted by tick bites in the summertime. So usually we try to collect the ticks. Now, these ticks are very small deer ticks. You can barely see them with the human eye. And after they bite you, they leave a bullseye rash. And you can tell it's a bullseye rash. It's very obvious, very evident. Okay, it looks just like a bullseye. It's got a ring around it with a red center. The problem is Lyme disease can cause a lot of problems if it goes untreated. So cardiac, joint problems, headaches, fever, dry cough, but neurologically, it can also cause abnormalities. But your big ones you're going to see are cardiac and joint. Herpes simplex encephalitis. This could come from herpes simplex 1. Okay, extensive necrosis and hemorrhage in the brain. And that herpes likes to lay dormant, remember, in that trigeminal nerve ganglion. Eventually, it can travel to the brain and cause damage to the frontal and temporal lobe. Amoebic meningoencephalitis, and this is caused by amoeba Naegleria fowleri. We have seen this summer in at least 2 cases. One was in Minnesota and one was in Georgia. So usually this is going to be lakes, okay? And lakes are typically warm water. Like the ocean can be a little bit cold, but lakes are typically warm. Okay, so they like to swim in that warm water. This can lead to inflammation, swelling of the brain and the spinal cord. And we don't see it that often, but it is fatal. Rabies, this is also viral. It's transmitted by the bite of an animal with rabies. So, all these people that are having their kids play with squirrels and raccoons and everything else, those animals don't like people. And usually they don't come out. If it's a animal that is supposed to be out at night only and it's out in the daytime, you can almost be assured it has rabies. Now, we do see a lot more animals coming out in the daytime now because we're populating their areas and we're taking away their food supply. But they're dirty. We don't want to play with them. They're not meant to be like us, and they're not all meant to be pets. So this rabid animal bites somebody and it contaminates. It transplants the virus, okay, into the peripheral nerves where it's going to travel in the central nervous system, and it's going to cause inflammation and necrosis, especially in the brain stem. Okay, brain stem is where your vital life is. The basal ganglia. So these people are going to have headache, fever, hyperirritability. The virus also travels to the salivary glands. So that's going to cause them to have a problem with swallowing. And they're going to be afraid of the fluids because they're aspirating or they can't swallow. And if it goes untreated, okay, it's going to lead to respiratory failure and death. So the muscle spasms that this person are going to have are going to cause difficulty with the swallowing and foaming at the mouth. Tetanus, this is caused by Clostridium tetani. I talked about this when you step on a rusty needle. Okay, there's endospores. And these spores can survive for a long time in the soil. And then when they come into the body, they turn into a vegetative spore. So they can thrive without oxygen deep in the tissue, like if you puncture yourself stepping on a nail, okay? It's an exotoxin that enters the nervous system, leads to tonic muscle spasms. So these clients will have jaw stiffness, difficulty swallowing, stiff neck, headache. So again, we can get the vaccination that could prevent this from happening. You have to get it every so many years. Poliomyelitis. This is the polio virus. It's pretty rare in the United States, but it is evident in other parts of the world. There is an immunization program trying to combat the epidemic that is occurring right now in West and Central Africa. There are a large number of kids infected and faced with the threat of paralysis. The polio virus itself is highly contagious through either direct contact or oral droplets. And it reproduces in your lymph tissue, in the oropharynx, in the digestive tract, and then it enters the blood and the central nervous system. It will attack motor neurons in the spinal cord and the medulla oblongata. It can cause flu-like symptoms, but eventually paralysis, respiratory failure. Symptoms are fever, headache, vomiting, and then stiff neck pain and flaccid paralysis. Herpes zoster or shingles. This is caused by varicella zoster in adults. And we usually see it after they've already had an infection with chickenpox or varicella. So usually they have that varicella infection in childhood. Usually happens along a cranial nerve or one dermatome in the area of the skin that's innervated by the spinal nerve. And these clients will have pain, paresthesia, and a vesicular rash. It develops along that line, that nerve line. It's usually on one side of the body. So this can happen in the face, along the trigeminal nerve, or on the path of a lumbar nerve from the spine, where it goes around like one side in the hip area. The lesions last for several weeks and then they usually clear up. It can cause what we call post-herpetic pain, where they have pain after the shingles that can last for a really long time, and it can be very difficult to treat because it falls on the same line of pain like fibromyalgia and things of that nature. If they're immunocompromised, the lesions can spread locally. It can cause visual impairments, and there is a vaccine available for shingles. Post-polio syndrome, this can happen anywhere between 10 and 40 years after someone had polio. And it's going to cause progressive, debilitating fatigue, weakness, pain, atrophy of the muscles. The more severe the first infection was, the more severe the post-infection would be. Reyes syndrome, I would know this. They like to ask about it. All right, this is not really, they don't really know why this occurs, but it's attributed to a viral infection like the flu in young kids that are treated with aspirin. So the virus usually happens about 3 to 5 days after the first viral infection. Major pathological changes will occur in the brain and the liver. I would know that. They can develop non-inflammatory cerebral edema, increased cranial pressure, high ammonia levels in the brain because of liver dysfunction. The liver will enlarge and develop fatty changes, and it could progress to acute liver failure. The liver enzymes will be elevated here, and they can develop metabolic abnormalities like hypoglycemia, increased lactic acid levels in the blood and the body. This can cause acute encephalopathy, and the kidneys can be affected by the changes of the fatty liver and the fatty changes in the body, causing increases in the urea and creatinine levels. So the BUN and creatinine levels, we would see changes there. Guillain-Barré syndrome, usually people develop this after an infection. One of the main ones that they develop it after is post-infectious polyneuritis. This is an inflammatory condition of the peripheral nervous system. And Guillain-Barré syndrome is an abnormal immune response. It could be autoimmune. They're not 100% sure. But what they do know is usually the person either got some sort of immunization or they had some sort of viral infection first, and then they developed Guillain-Barré. It causes inflammation, a lot of lymphocytes to develop. We'll see demyelination and axon destruction in the peripheral nerves. These changes can cause impaired nerve conduction, especially in the motor fibers. So that's those efferent fibers. And remember, those are responsible for conducting some sort of action in the body. Also, the afferent or sensory fibers can be involved. Initially, the inflammation and degenerative processes affect the peripheral nerves in the legs. We call this an ascending. So the weakness and the damage will start in the legs, and then it moves its way up to the chest, the trunk, and the neck. It'll affect the spinal nerves in those areas, and these patients could end up on a ventilator. So when that ascending paralysis starts to involve the diaphragm and the respiratory muscles, they could end up on a ventilator. The recovery here is usually spontaneous, and the manifestations will diminish in reverse order. So they'll start to feel better around the neck, the chest, and then it'll move down towards the feet as they improve. So the signs and symptoms for Guillain-Barré are progressive muscle weakness and areflexia beginning in the legs, ascending flaccid paralysis accompanied by paresthesia pain, general muscle aches. Speech and vision can be impaired here. If swallowing or respirations are affected, a life-threatening situation develops. So again, they might end up on a ventilator here. And they also could present with things like cardiac arrhythmias, blood pressures that are fluctuating. They might not be able to sweat. Brain injuries, these involve skull fractures, hemorrhage, and edema, or direct injury to the brain tissue. So the injury could be mild, causing just bruising of the tissue, or it could be severe and life-threatening, causing destruction of the brain tissue and massive swelling of the brain. The skull is supposed to protect the brain, but it also could destroy it by bone fragments penetrating or compressing the brain tissue, and by its lack of ability to expand whenever it starts to develop pressure. It can't expand in order to relieve that pressure. So that could also cause a life-threatening condition. Types of head injuries are going to be concussion, which is a mild traumatic brain injury. It's reversible typically. This is from some mild strike or blow to the head that causes excessive movement of the brain. It disrupts the neurological function. It could lead to a loss of consciousness. Amnesia or memory loss and headaches can happen after a concussion, but usually these people recover with no permanent damage within 24 hours. However, if someone were like a boxer or a football player and they suffered these multiple times, then we could have progressive permanent brain damage. A contusion. In a contusion, we have bruising of the brain tissue. We'll see rupture of small blood vessels and edema from the blow to the head. The possibility of residual damage depends on the force of the blow and how badly the tissue is injured. A closed head injury can happen when the skull is not fractured, but brain tissue is injured. The blood vessels can be interrupted by the force exerted against the skull. Extensive damage happens when the brain is rotated with considerable force. Open head injuries involve fractures or penetration of the brain by some object. Am I missing a slide here? It looks like I'm missing a slide. All right. Depressed skull fractures. Let's go back. Depressed skull fractures involve displacement of a piece of bone below the level of the skull. So when it's depressed, it presses down, okay, and compresses the brain tissue inside the brain. It's going to interrupt the blood supply, more than likely, and put pressure on the brain. Whoop, what happened there? Can you guys still see the slideshow?
Yes.
Yes.
Okay. All right, a basilar fracture, this occurs at the base of the skull. So remember, we were talking about the leakage of the cerebral spinal fluid through the ears or the nose being possible here. These clients will also usually have two black eyes. We call that raccoon sign. And a lot of times they'll have a big bruise at the mastoid process. We call that a battle axe sign or a battle sign. The bruise indicates that there's a fracture at the bottom of the skull. A battle sign is a bruise that indicates fracture at the bottom of the skull. And people with battle sign will also have the raccoon eyes, which is bruising around the eyes related to the skull fracture. You'll also notice clear fluid from the ears and the nose, And this is because there's a tear in the protective covering of the brain from the trauma. Contracoup injury. This occurs when the brain on the contralateral side of the damage is injured when the brain bounces off the skull. This can be secondary to acceleration or deceleration injuries. So, like when you hit the windshield and then you bounce back, it causes the brain to rebound against the opposite side of the skull, and it usually causes some sort of minor damage. So that's just showing you that rebound effect for the contracoup and the depressed fracture where it pushes the bone down into the brain tissue. I would know those two for sure. Primary brain injuries are direct injuries like laceration or some sort of crushing of the neurons, the glial cells, or the blood vessels in the brain. They can involve lacerations or compression by a piece of tissue, of bone or foreign object, or rupture or compression of the blood vessels. The application of unusual force may rotate or shift it inside the skull. The brain tissue can be damaged by the rough, irregular surface of the skull or by movement of the lobes of the brain against each other. That's known as a shearing injury. So the brain itself can move and be caused by either damage of it rubbing against the skull or even rubbing against itself. Secondary brain damage is caused by development of additional injurious factors. So this would be things like cerebral edema that developed because of the injury, hemorrhage that developed because of the injury, a hematoma that developed because of the injury. Remember I said if there's bleeds in the brain, it can cause cerebral vasospasms, and that's because of the injury, and ischemia or infection because of that injury or what happened there. So that would make it secondary. All right, so I would just look through this. This is just telling you some of the effects that can happen whenever there is a particular type of brain injury, all of which we've already talked about. So any trauma to the brain tissue can cause a loss of function in the area of the body associated with that brain tissue. Cell damage, bleeding causes inflammation. It can cause vasospasm to the vessels around the site of the injury. It can cause increased cranial pressure, ischemia, and dysfunction. The central area of damage will undergo necrosis and be replaced by either scar tissue or a cyst. Now, hematoma is collection of blood in the tissue. It comes because of ruptured blood vessels. It can develop right after an injury or after a few hours or days. It can also occur after surgery. Hematomas and hemorrhages are classified by their location in regards to the meninges themselves. So if you look here, an epidural hematoma would be in that epidural space. So it's going to be right above the dura. A subdural hematoma is going to be right below the dura and between the arachnoid area. And then an intracerebral hematoma, which can be in the center of the brain. Intracerebral hematomas come from contusions or shearing injuries and can develop a few days after the injury. Subarachnoid hemorrhages usually occur in the space between the arachnoid and the pia. So it's below the arachnoid because it's sub, okay? And it's associated with traumatic bleeding from the blood vessels at the base of the brain because the blood mixes with the circulating cerebral spinal fluid. All right. That was just showing you a picture. You guys have that in your slides, okay? All types of hematomas lead to pressure on the adjacent tissue and cause an increase in cranial pressure. So we might see this in someone that has a sports injury to the head, an automobile or a motorcycle accident, and falls can be a cause of this. And actually, there's a kid right now. I don't know if you guys are watching the news or not, but from locally, he doesn't live too far from my area. Okay, he's from Cherry Hill, New Jersey, I believe it is, and he got hit with a baseball during baseball practice. All right, in the back of the head, right around his neck area, and so he's currently in critical condition. Okay. He does have ICP. I believe he might even be in a coma. Okay. And, you know, we don't know what's going to happen with him. But again, here's a sports injury. You know, it just happened in routine warm up. It was nobody's fault. But how fast do these kids throw these balls in Little League? What do you think? Anybody have an idea? Some of them are going at 80 to 100 miles an hour. So can you imagine a baseball going at 80 miles an hour and hitting you in at the base of your neck, okay? Or at the top of your neck, at the base of your skull, I meant. A baseball hitting you there, what do you think it would do to you? You guys still with me? I don't hear nobody talking.
Yes.
Okay. All right, so in all types of hematoma, the bleeding is going to cause pressure on the tissue and an increase in cranial pressure. So they'll have characteristic focal signs and general signs of increased cranial pressure. So seizures can be focal here, meaning they affect one portion of the brain, or they can be generalized, meaning they affect multiple portions of the brain. And these can be stimulated by that irritating blood there. Cranial nerve impairment, especially if they have that basilar fracture at the base of the skull, because a lot of cranial nerves come in there. Remember that? Otorrhea or rhinorrhea, which you need to know those terms. That's when that cerebral spinal fluid is leaking from the ear or the nose. And fever, because the hypothalamus controls your temperature. All right, so this could be impaired, or cranial nerves could be impaired there. They could develop an infection. And stress ulcers from gastric secretions increasing here. All right, spinal cord injury. This usually results from a fracture or dislocation of the vertebrae that compresses, stretches, or tears the spinal cord. Supporting ligaments and the intervertebral disc are damaged here. Multiple injuries can occur in the spine that provide more mobility but have less support. So, like C1 to C7 and T12 to L2. Cervical spine injuries come from hyperextension or hyperflexion of the neck with possible fracture. So, usually we'll have damage to the disc and the ligaments. This can cause dislocation, loss of the alignment of the vertebrae, compression of the spinal cord. It can be some injury that causes dislocation of the vertebrae, and that can crush or compress the spinal cord and compromise the blood supply. Now, compression fractions, these cause injury to the spinal cord when we have great force applied to the top of the skull. So this would be like if you dove into an empty swimming pool, or if you jumped, like there was a fire in your apartment building and you had to jump from the third floor and land on your feet. Okay? That, or if you fell and landed on your head. Okay? So the height would have to be really pronounced if you jumped and landed on the feet. But from any distance, if you fall and make direct contact with your skull to the ground, you can have this type of injury. The shattered bone here is compressed, protrudes, exerts pressure against the spinal cord. Sharp edges of the bone fragments can lacerate and tear the nerve fibers and the blood vessels, and the spinal cord damage could also occur from penetration injuries like a stab or bullet wounds. All right, so dislocation of any vertebrae can cause a crushing or compression issue and compromise the blood supply. Hyperextension injuries can be caused by compression of the spinal cord, okay, or from hyperextension or hyperflexion of the neck for some reason. So you see the guy falling down the steps and it pushes the neck, the head backwards, and it causes the compression there of the cervical spine. If you see like where that head compresses backwards there, you can see that that injury is going to be caused there at the back of the neck. Okay, and then compression fractures can cause injury to the spinal cord when great force is applied to the top of the skull or to the feet.
Professor Loge,
Yes.
I've heard you can also get like a spinal cord injury from like jumping from a high point to like a large pool of water. I've heard people get spinal cord injuries from that.
Yeah, absolutely. So, here's the thing. People like to do a lot of like diving off of cliffs and pools and stuff like that. Now, your Olympic pools are set up so that if you're jumping from a tower of 10 feet high, that the water is deep enough that you're not going to hit it and make that impact. Okay. But what happens is people don't often check the water where they're jumping or diving into, and it's much shallower than what they know. So this actually happened to a friend of mine in high school. We used to go swimming at the river all the time. Now they really don't want kids swimming in the river, but that's where we used to swim. And we used to go to a place called Jabberwocky Lane and jump off the railroad trestle. And the railroad trestle would go down into the body of water, which most of the time the water went down there was deep enough. But the problem that you have in the river is that the tide shifts things in there all the time, and the sandbars, there's sandbars in the river, and these sandbars can shift. So where we were typically diving at, the sandbar isn't typically there, but one day we went there and the sandbar was there. It moved. No one checked the water below first. He was the first one to go in. Okay. And he dove in head first. He hit the sandbar. And of course, he went out of there by ambulance and he was in a wheelchair for the rest of his life.
Wow.
All right. Vertebral fractures can be classified as simple, which is a single line break. Mostly they're going to ask you, I believe, about the compression one. So you got to know about that, okay? This is crush or shatter bone in multiple fragments. So we're just talking about this, diving from a high area in a shallow pool or no water, or jumping from a high area on your feet. Or if you had like a problem with your disc, okay? And it caused this compression to occur. A wedge, which is a displaced angular section of the bone, or dislocation where the vertebra is forced out of its normal position. So we'll see a lot of these involved in like MVAs, motor vehicle accidents. Spinal cord injuries are often unstable, so we got to immobilize the person right away to prevent any additional changes. So usually we're going to do C-spine and move them on a specific board and all that. Not supposed to move them, but and clients aren't supposed to move themselves. But we know realistically in certain areas, they're going to get up on their own. You can't make them lay there, and sometimes they'll just get up and move. but you're not going to move them. All right, so the damage to the spinal cord could be temporary or permanent. Nerves in the spinal cord do not undergo mitosis, but the axons can regenerate. Laceration of the nerve tissue by bone fragments can cause permanent loss of conduction in the affected nerve tracts. So remember, those nerve tracts are carrying certain signals to the brain and back out to the body. If the cord is severed for any reason or crushed, they could have irreversible loss of all sensory and motor function, either at the level of injury or below it, or both. And partial transection or crushing injuries, sometimes if it's only partially transected or severed, then they can have return of some of the function over time. So if they have just bruising to the area, probably they'll have edema, maybe some mild bleeding. It could temporarily impair the conduction of the nerve impulses, but it usually will return. If they have prolonged ischemia or lack of blood flow to the area and necrosis, that can lead to permanent damage. The bleeding and the inflammation can cause additional pressure and interfere with the blood flow. Edema and hemorrhage can extend several segments above and below the level of injury, and damaged tissue also can release things like norepinephrine, serotonin, and histamine. And these can lead to vasoconstriction, additional ischemia, and possible necrosis. Also, enzymes can be released there that can cause additional inflammation and necrosis. And loss of function may originally look to be extensive, but then over time it could subside if the edema subsides. They could have partial recovery or some recovery or no recovery. Remember, we talked about the dermatomes earlier, and we assess these using a map. And this can tell us about the amount of damage in the spinal cord area or if something's returning. So, also, originally, we might not get a positive response on one of these dermatomes, but then later on, as the person starts to heal and recuperate, we might see that return. Okay, so this could tell us about recovery as well, based on the degree or damage to that particular area, wherever it is on that map that correlates with where the injury is. If the injury occurs in the cervical region, inflammation can extend up to level C3 and level C5, and that can interfere with phrenic nerve innervation. Now, I already told you guys that the phrenic nerve innervates the diaphragm. And so that's going to also innervate respiration or help you with your respiration. And also, you have nerves right there that are innervated for your intercostal muscles, which you also need for respiration. So if that area is damaged, these clients might need a ventilator. The spinal shock is the initial period right after the injury. The impulses cease in the nerve tracts in the gray matter. This is known as spinal shock. The extent of the injury, the amount of bleeding, and the need for surgical intervention would determine how quick they recover. Inflammation will usually subside. Phagocytes will come in and get rid of the damaged tissue. Scar tissue will form here. The reflexes will resume in the spinal cord below the level of injury, and any undamaged tract will continue to conduct impulses through the level of damage. Control of reflexes below the level of damage is lost. And there's no communication here with the higher levels of the brain. All right, so this is just showing you if the injury occurs here, this is what would be lost. So take a good look at it. There are two stages in the post-traumatic period of spinal shock, the early stage and increasing impairment, and then we have recovery and recognition of the extent of functional loss. During the initial period of spinal shock, all neurological activity ceases either at, below, and often slightly above the level of injury. No reflexes are present, including skeletal muscle, sensory, autonomic systems like the bladder and bowel function. This can be just a few days or it can go on for weeks. During the period of spinal shock, signs are flaccid paralysis, sensory loss at and below the area of injury, absence of all reflex responses, and loss of control of autonomic function. So, how would you know spinal shock was resolving? The reflexes will start to return. Okay? In patients with a cervical injury, this can include loss of control of vasomotor tone, blood pressure, diaphoresis, and body temperature, as well as emptying of the bowel and the bladder. The blood pressure is low and liable, and urinary retention and paralytic ileus are present. Recovery from spinal shock is indicated by gradual return of reflex activity below the level of the injury. No impulses, including reflexes, can pass through specific areas of damaged neurons. In most cases, hyperreflexia develops because the normal inhibitory impulses cannot reach the spinal cord level below the injury. After recovery from spinal shock, the return of reflexes, spastic paralysis, sensory deflexes, and reflex or neurogenic bladder and bowel function are present below the level of damage. Gradually, the extent of the permanent damage is revealed. Voluntary motor activity and sensory impulses are blocked at the level of damage. Effects of permanent damage will depend on the level at which the spinal cord trauma occurred. For example, if a cervical injury affecting motor and sensory function in the arms, trunk, and legs occur, respiratory function, sympathetic nervous system function T1 to L2, and sacral parasympathetic parasympathetic fibers could be affected here. In patients with cervical injuries, respiratory function may be of concern because of that phrenic nerve impairment and loss of the intercostal muscle innervation. Blood pressure and body temperature may be all over the place because central control of vasomotor tone and diaphoresis is lacking here. You should know these terms, okay? Tetraplegia is paralysis in all four extremities. It might also be called quadriplegia. Paraplegia is paralysis in the lower part of the trunks and the legs. And then ipsilateral paralysis and contralateral loss of pain and temperature sensation depends on the point of decussation and location. So I told you decussation is what? Who remembers? That's where they cross over in the body, okay? The nerves cross over and it controls, the left side controls the right side controls the left side. So decussation is where they cross over to go to the opposite side of the body or the brain. Trauma in the lumbar region interferes with function in lower extremities and sacroparasympathetic nerves. Partial cord injuries can lead to different patterns of impairment. For example, ipsilateral paralysis, contralateral paralysis, loss of pain, temperature sensation, depending on the point of decussation or crossover and the location of the specific injured tracts. So again, decussation is the crossing of the nerve fibers in that central nervous system, where they cross over from one side of the body to the other. Okay, so this is actually telling you now what's going to happen here because of this, is this autonomic dysreflexia. So with the injury of the cervical spine, stimulation of the sympathetic system can result in autonomic dysreflexia, a serious complication caused by a sensory stimulus that triggers a massive sympathetic reflex response that is not controlled by the brain. The trigger can be from noxious stimuli in the body. So what does that mean? Something in the body that's irritating it. And usually with autonomic dysreflexia, it's either going to be they need to urinate and they're not able to put that urine out for some reason, or the bladder is full and the calf bag is full. Okay. Or they can't poop. They're constipated. Things that could also cause this are tight clothing, extreme changes in the temperature in the room. A sensory stimulus to sympathetic nervous system below the level of injury can stimulate the entire chain of sympathetic nervous system ganglia, causing excessive vasoconstriction. We'll see a sudden increase in blood pressure, severe headache, and visual impairment. Bradycardia will accompany the syndrome because the baroreceptors sense the high blood pressure and respond through the vagus nerve to slow down the heart rate. So here, if you look at this, like we have bladder distension here, okay? The bladder distension is the stimulus that's going to trigger this to occur here, this autonomic dysreflexia. So the bladder's distended, the stimulus enters the spinal cord and goes to the area of the spinal cord where it's damaged. The stimulus there is blocked, so it activates the sympathetic nervous system below the lesion there. The sympathetic nervous system causes systemic vasoconstriction because remember, that's what it does. It increases the blood pressure, okay? And that is going to lead to a headache and visual problems. The baroreceptors sense the high blood pressure. That causes the vagus nerve to be stimulated, and that's going to slow down the heart rate. The vagus nerve will also cause that slow of the heart rate and bradycardia. That will inhibit the sympathetic nervous system. The sympathetic nervous system is inhibited there because of the blockage or the damage to the spinal cord. Okay? So usually this would trigger the sympathetic nervous system from the brain, but that can't happen because we have damage in the spinal cord. So it's going to inhibit that sympathetic nervous system. And in order to lower the blood pressure here, we would have to remove the cause of the stimulus. So in order to fix this person, we're going to have to undistend that bladder. So empty that bag, get rid of that bladder, or if it was caused by pain, we would have to treat that pain, get rid of that pain. The blood pressure is going to go up really high. The heart rate is going to go down. And that's a problem. We're going to have to treat it. Okay, so in autonomic dysreflexia, this chart is just showing you once again, okay, the stimulus happens below the level of injury. So the distended bowel or the bladder there. Okay. That causes that massive sympathetic response in the body. widespread vasoconstriction. That's going to cause the blood pressure to go up, or hypertension. That's going to stimulate your baroreceptors, and that's going to slow the heart rate down. And then the inhibitory signals try to go down from the sympathetic nervous system, but they're blocked there because of the damage. So now we have to give medication or do something else. First, remove the stimulus, and then if that doesn't work, we may have to give medication here to decrease the blood pressure. Other complications of spinal cord injuries are urinary tract infections, pneumonia, skin breakdown, spasms, pain, depression, contractures from the muscle spasms, decubitus, respiratory urinary infections, a problem with sexual function. It can be either sensory and psychological because of blockage from the injury. Also, men can have what we call neurogenic reflex erections here. Okay, so penetration depends on being able to sustain that reflex, which can be hard if they have a high spinal cord injury. Women will usually resume their menstrual cycle once they've recovered from the acute trauma period and they can bear children. Again, they'll need to be closely monitored. All right, hydrocephalus, spina bifida, and cerebral palsy. All right, so this is from, I already talked about this a little bit, too much cerebral spinal fluid in the skull. There's two types, you have to know the difference, non-communicating or obstructive. It occurs in babies, and in non-communicating, the flow of cerebral spinal fluid is blocked. In communicating, the problem is those little villas that are supposed to suck up the cerebral spinal fluid and put it back into circulation are not working. So communication, the body is not reabsorbing it appropriately. In non-communicating, we have some sort of obstruction of the cerebral spinal fluid. So hydrocephalus is when we have too much cerebral spinal fluid in the skull, compressing the brain tissue and the blood vessels. In the majority of cases, production of cerebral spinal fluid is normal, but there's a problem with the amount reabsorbed. Developmental abnormalities is the most common cause here, either stenosis or atresia. Obstruction can develop at any age from tumors, infection, or scar tissue. Meningitis can cause obstructive hydrocephalus in the acute infection phase or lead to fibrosis in meninges, causing a problem with absorption. In neonates, the skull can expand to some degree in early stages of hydrocephalus to relieve the pressure. But if the condition is not treated, brain tissue would be permanently damaged here. In older children and adults, the pressure will increase much more rapidly because the bones are already fused there in the skull. And so the skull is not able to expand to accommodate the increase in the pressure. Causes of it are developmental abnormalities, again, stenosis or atresia or tumor, infection, or scar tissue at any age. Because these sutures of the skull are not yet closed, the baby's head will enlarge beyond the normal size as the amount of fluid increases. Excess cerebral spinal fluid will accumulate because more is produced than absorbed, and because of the obstruction to the flow. So this is non-communicating hydrocephalus. This usually comes from some sort of developmental abnormality like stenosis or a neurotube defect or myelomeningocele and Arnold-Chiari malformation. The obstruction causes an increase in the back pressure of fluid in the ventricles of the brain, causing the ventricles to dilate or enlarge and compress the blood vessels and the brain tissue. In communicating hydrocephalus, absorption of cerebrospinal fluid through the subarachnoid villi is impaired, causing increased pressure of cerebrospinal fluid. The skull expands in the early stages to relieve the pressure, but if not corrected, the brain tissue is permanently damaged. Because the sutures of the skull are not yet closed, the baby's head can enlarge beyond the normal size as the fluid increases. In older children and adults, that ICP will be rapid because of the lack of that openness, because the sutures are already fused there. The amount of brain damage will depend on the rate at which the pressure increases and the time of period that it remains increased until relief occurs. Brain damage will result in major physical disabilities and intellectual impairment. I'm going to go to the next picture. This is the one your book gives. Okay, this is the one I'm giving you because this is, you can see the skull getting bigger there. Those are the sunset eyes. Okay, they call them sunset. If you notice, usually you can't see the pupil. You can just see the top part of the color of the eye, maybe a tiny bit of the pupil. All right, neurotube defects. Spina bifida is a group of neurotube defects. These are congenital and they're a developmental defect with myelomeningocele occurring in many. The problem is failure of the posterior spinous process on the vertebrae to fuse. This allows the meninges and the spinal cord to herniate and leads to neurological impairment. There are three types of spina bifida. Spina bifida occulta, in where the spinous processes do not fuse. And you can usually tell this because I have a little tuft of hair on their back. Meningocele is the same bony defect, so the spinous processes don't fuse, but we also have herniation of the meninges through the defect. And the meninges and cerebrospinal fluid form a sac on the surface of the back. Transillumination will confirm the absence of nerve tissue in that sac. And the most severe is myelomeningocele. This is the most serious form of spina bifida. We have herniation of the spinal cord and the nerves along the meninges and the cerebral spinal fluid, causing considerable neurological impairment. In spina bifida occulta, the spinous processes do not fuse, but the herniation of the spinal cord and meninges does not happen either. Okay, so here it's just those spinous processes that don't fuse. You might not see it, and they'll have that dimple or that tuft of hair over the site. With meningocele, we'll also have the lack of fusion there, okay? But also some other things are going to occur here. So, herniation of the meninges through the defect. The meninges and cerebral spinal fluid form a sac. It's going to be on the outside surface. So remember I said these kids could get meningitis from E. coli because the sac is on the outside of the skin. And if we don't keep that area sterile, poop, baby's poop, it goes right up the diaper and right up the back, right? It could go right into that area and cause an E. coli infection. Neurological impairment is not usually present with the meningocele, but infection and rupture of the sac could lead to neurological damage. And then myelomeningocele, which is the most serious form, we have herniation of the spinal cords and the nerves, along with the meninges and cerebral spinal fluid, causing considerable neurological damage. The location and extent of herniation determine how much function is lost, and we also see this in conjunction with hydrocephalus. So again, you'll see spina bifida is the first picture here with the tuft of hair. And then on the other two, you see the sac develops there on the outer portion of the back. Spina bifida has a multifactorial basis. Genetic and environmental factors cause it to develop. There are also high familial incidences of spina bifida and associated defects like anencephaly. This is where the baby is born without the cerebral hemispheres. And a lot of times the head is open. You can look right down in it when the baby's born. Environmental factors are radiation exposure, gestational diabetes, deficits of vitamin A or folic acid. So we recommend folic acid supplements, and we do that teaching to anybody at risk for becoming pregnant. Alpha fetoprotein has leaked into the amniotic fluid from the defect around the fetus. So sometimes we can see this when we draw the amniotic fluid or we do an amniocentesis. Also, we can look for the spina bifida as well. Signs and symptoms. So for meningocele and myelomeningocele, we'll see that protruding track over the spine. In myelomeningocele, we'll also might see additional damage, okay? When we transilluminate it, meaning we put a light over it and we look at it. Sensory and motor function at or below the level of the herniation is impaired in myelomeningocele for sure. Some degree of muscle weakness or paralysis could be present in either or both. Bowel and bladder control, bowel and bladder control impairment here. And depending on how bad the damage is, the reflex and the sphincter control can be affected here, so they can have both fecal and urinary incontinence. All right, cerebral palsy. This is a group of disorders that includes motor impairment. This is caused by genetic or abnormal formation of the baby or the functional brain areas specifically of the baby. Infection or damage to the brain in the perinatal period. So damage usually occurs in other areas of the brain, resulting in a clinical presentation that is highly variable depending on the areas affected for these kids. Damage can occur either before, during, or shortly after birth, and it doesn't progress. It's non-progressive, meaning whatever they're born with is what they're going to have. It doesn't get worse. The brain tissue is altered by some malformation from either mechanical trauma, hypoxia, hemorrhage, hypoglycemia, too much bilirubin, infection, and it causes necrosis. In some cases, generalized necrosis and atrophy of the tissue in the brain have occurred. In other cases, it only affects a couple of areas. We can have single or multiple factors that can cause cerebral palsy. Hypoxia or ischemia is the major cause of brain damage. It can occur prenatally, perinatally, or postnatally. Hypoxia can be caused by placental complications like difficult delivery, vascular occlusions, hemorrhage, aspiration, respiratory impairment, high bilirubins, RH. Blood incompatibility can cause kernicterus, which I talked about. This is when we have too much bilirubin and it crosses the blood-brain barrier and causes damage there. Drugs, cocaine can lead to this. Hypoglycemia or metabolic abnormalities in either mom or baby. All right, they have a couple different types of cerebral palsy. I wouldn't focus too much on this, but you do want to know what the actual disease is, what causes it, and what it would look like. Okay, so they do have some sort of usually paralysis or difficulty with movement here. Okay, as you can see, either some sort of spastic issue, dyskinesia, which is problems with coordinating or movement, or ataxia, where they have problems with their gait or loss of balance. So all these are going to be seen, or some of them may be seen in some types, and others may be seen in other types. Some of them can have a mixed type too. Again, your book goes pretty intense into all three types. So just have a basic understanding about how all these types could help us. Again, it's damage to the pyramidal tracts and the cortex, all of which control your motor function. All right, the extrapyramidal tract, the basal nuclei, again, motor function. And damage to the cerebellum. Cerebellum is going to be coordination and balance. They can have problems intellectually, problems with communication and speech, seizures, and visual problems. Most of them have normal intelligence, but not all of them. And because of the motor issues, the impaired mentation and visual hearing issues that they might have, these all affect their ability to communicate and to speak. Seizure disorders. Again, this is excessive neuron, okay? Uncontrolled, excessive damage of neuron, discharge of neurons in the brain. It could be local, meaning it affects one part of the brain, or generalized, where we see multiple parts of the brain. And they can be caused by infections, tumors, increased cranial pressure, fever. So we have sudden, spontaneous, uncontrolled depolarization of the neurons, causing abnormal motor or sensory activity problems or loss. The neurons are hyperexcitable. They have a lower threshold for stimulation. Any physiological change like alkalosis, flashing lights can irritate the neurons and cause a seizure to happen. So if you've ever heard that someone has seizure disorders, they shouldn't be like in a nightclub with disco lights flashing off and on. That can cause the seizure to occur. Certain medications can lower the seizure threshold. So we have an altered pattern of electrical activity or brain waves. We can measure that on an EEG, and that can sometimes tell us about the type of seizure. Complications can occur like status epilepticus, especially if they have the tonic-clonic. Remember, that's the most dangerous type of seizure. It's going to cause the most drama with the loss of consciousness, loss of control of the bladder, thrashing about. And status epilepticus, remember, is back-to-back seizures. That's a medical emergency. A lot of your seizures are idiopathic, so the idiots don't know why we have it, but it can be triggered by certain things like loud noises, bright lights, stress, hypoglycemia, changes in medication, hyperventilation, withdrawal from sedatives or alcohol, fevers or infection. Prodrome signs are what we see before the infection, before the seizure occurs. The aura, I talked about that, right? This is like the lip smacking, the smell, the vision, right before something happens. Loss of consciousness, the person falls to the floor. You can have partial seizures. This is going to happen just in part of the brain. Again, that EEG can help us determine that. We don't care about treatment. All right, next is multiple sclerosis. So the difference between this and Guillain-Barré syndrome. Remember, in Guillain-Barré syndrome, it's demyelination of the peripheral nervous system, okay? Don't get them mixed up. And it causes that ascending paralysis where it travels up the legs and then to the respiratory system and the face. In multiple sclerosis, we have progressive demyelination of neurons in the brain, the spinal cord, and the cranial nerves. Okay, so the loss of that myelin, remember, myelin helps with conduction of the impulses, with the speed. It's sort of like insulation around the nerves. And this is going to affect your motor, your sensory, and your autonomic function. It affects all the nerve fibers, motor, sensory, and autonomic. So we'll see changes in the white matter, changes in the spinal cord. The earliest lesions occur as an inflammatory response in cells that don't normally enter the brain or the spinal cord, but here they're going to enter that area and attack the neurons. And that's going to cause loss of the myelin in the white matter of the brain or spinal cord. Research says that there's a certain protein in the blood clotting mechanism that can trigger the immune response here. Large areas of inflammation and demyelination will become what we call plaques. And later we can actually see these in the ventricles of the brainstem, and in the optic nerves. The plaques will vary in size. And then initially the inflammation can subside and neurofunction can return. Please put yourself on mute. Please put yourself on mute. Please put yourself on mute. Right, so these large area of the brains can become inflamed and demyelination can occur. Plaques will develop here, and it's going to affect the ventricles in the brain, the brainstem, the optic nerves. They can go through periods of recurrence. So initially, the inflammation can subside and neural function could go back to normal for a short period of time. Okay, but eventually that neural degeneration will become irreversible and the function will be permanently lost. Every time it does reoccur, additional areas of the central nervous system are involved. So these people will have mild, slowly progressive patterns, and others will have rapidly progressive patterns in which this injury occurs throughout the body. Usually doesn't happen until about 20 to 40 years old, peaking around 30. The cause is unknown. It is believed to be autoimmune, but there are genetic and environmental components as well as immunologic components. And there's an increased risk of someone else in the family having it. This also could be attributed to nutritional deficits or a change in the blood flow to the neurons. So what we're going to see is, depending on how much demyelination has occurred in the brain and the spinal cord, we'll see things like blurred vision, double vision or diplopia, spots in the visual field known as scotoma, dysarthria. So we talked about dysarthria, right? Poor articulation. I talked about it with Lou Gehrig's disease. Now here's something else that we can see. Multiple sclerosis would also be affected. Weakness in the legs from the plaques on the cortical spinal tract, paresthesia if sensory nerve fibers are damaged, as the number of plaques increase, progressive weakness, paralysis extending to upper limbs, loss of coordination, loss of bladder, bowel, and sexual function, and then chronic fatigue here. So this slide is just showing you, okay, And I would just look over it. It's just showing you the steps, how it occurs there and what happens. It attacks the central nervous system. Okay, attacks the neurons, and it's going to affect that myelin sheath that goes around the nerves that have to do with transmission of your nerve signals in the body. Parkinson's disease. This is a progressive degenerative disorder. It causes dysfunction of the extrapyramidal system. So again, that has to do with movement. Okay, so we're going to see dysfunction of the extrapyramidal motor system, progressive degenerative changes in the basal nuclei, especially the substantia nigra, a decrease in the number of neurons in the substantia nigra secrete dopamine, an inhibitory neurotransmitter that causes an imbalance between excitation and inhibition in the basal nuclei. So that's going to have to do with movement because it should be balanced there when these signals are excited or inhibited to produce certain things in the body. So if we don't have inhibition, we're going to have excessive stimulation. And that excessive stimulation causes tremors when someone's sitting still, rigidity in the muscles, difficulty starting the movement, and postural instability. Patients with Parkinson's tend to have a reduced number of cortical neurons. That's characteristic of dementia. So that means it's going to affect their ability to remember as well. So primary or idiopathic Parkinson's, okay, usually develops around 60. So genetically, not a lot of research done because people would have had to go back and realize that someone else before me had it and do that testing before they died. It could be because of viruses or toxins. Toxins linked include manganese, carbon dioxide, and some pesticides. Parkinson's can happen after encephalitis, trauma, or vascular disease, and it can also be drug induced from phenothiazines or chlorpromazine, which is something we use in psychiatric patients, and we used to use it for like anesthesia as well. Early signs of Parkinson's would be fatigue, muscle weakness, and aches, decrease flexibility. A huge one is changes in the facial expression. So it doesn't happen spontaneously. The face becomes a little bit rigid there. Tremors in the hands and the feet, and they might have pill rolling motions where they rub their fingers against their. Let me just put the video on for a second. Oh, you can't see me because I got that other stupid thing on there. All right, but you're pushing your fingers and your thumb together, and you're making what we call pill rolling. You look it up, you'll easily find a picture of it somewhere. All right, and then later on, the tremors start to affect the hands, the feet, the face, the tongues. The muscles become even more rigid. That's going to give us a problem when we start to try to move. Movements will be slow. We'll lose some of those involuntary movements. Standing posture will be stooped and leaning forward. They'll have a propulsive gait, okay, and they lack the arm swinging when they move, which is a problem because when they lack that, it also could affect their balance. The propulsive gait will lead to things like short, shuffling steps, and the postural reflexes are impaired, so they can fall easily because they don't have those normal reflexes. And they have a hard time getting up out of chair. It might take them a really long time. They might move slow. All right. It also can affect their voice, their ability to chew and swallow. It can cause a lot of drooling, so we'll give them like atropine for that. And the face will look mask-like. That's usually a term they put on a test question. Okay, that rigid mask-like face. Again, that's because of the dopamine, that basal ganglia, that nigra striata all being affected there. And eventually it'll impair their communication abilities. All right, so in addition, autonomic issues are going to be urinary retention, constipation, orthostatic hypotension, which increases their risk for falls, urinary and respiratory tract infections, and dementia. All right, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. This can be identified with certain chromosomes, but they're still looking at this because they don't really know the cause. With Lou Gehrig's disease, it affects the motor neurons. So they have muscle wasting and sclerosis or hardening of those cortical spinal tracts. And remember, that's where the afferent signals and the efferent signals move across. So if that area is hardened, it can affect those signals being able to move there. It affects people usually between 40 and 60, and it really affects the upper motor neurons in the cerebral cortex and the lower motor neurons in the brain stem and the spinal cord, sensory neurons, cognitive function, and cranial nerves 3, 4, and 5 to the muscles are not affected. But there's no cure for this fatal disease. We'll see a loss of upper motor neurons in the cerebral cortex, and this can lead to spasticity, paralysis, hyperreflexia. Studies show that the glial cells or the astrocytes here secrete a neurotoxin causing the motor neurons to die. The loss of the upper motor neurons causes spastic paralysis, hyperreflexia. Damage to the lower motor neurons causes flaccid paralysis, decreased muscle tone, and reflexes. They'll have progressive muscle weakness, which usually is going to affect their respiratory function, and that's ultimately what causes them to die. Myasthenia gravis. This is an autoimmune disorder. Here, antibodies are going to attack acetylcholine at the neuromuscular junction. Now, acetylcholine is absolutely essential for muscle contractions to occur. The cause is unknown. Some of these patients have problems with their thymus or benign tumors, and it occurs between the ages of 20 and 30 for women and over the age of 50 for men. We'll have destruction, so autoantibodies attach to the acetylcholine receptors and block and destroy the receptor site, so that stimulation of the muscles cannot occur, and this causes weakness of the skeletal muscle, fatigue. The facial and ocular muscles are usually affected, and then it follows with the arm and the trunk muscles. So it starts in the facial area and moves itself down. These clients are at risk for dysphagia and aspiration. So what we'll see is muscle weakness, fatigue, diplopia, ptosis, impaired speech, spontaneous facial expressions are lost here, and chewing and swallowing becomes difficult. They might not be able to hold their head up. It might droop a little bit. All right, Huntington's is inherited. This is autosomal dominant, which means they have to inherit only one gene. If the parent gives them a bad gene for this, they're going to have it. Okay, autosomal dominant means you only have to get one gene. It does not usually manifest until people are around 40. It causes atrophy of the brain and it's progressive. So the neurons will be degenerated, especially those in the basal ganglia and the frontal cortex, dilation of the ventricles, depletion of GABA, that's an inhibitory neurotransmitter, And then the acetylcholine levels in the brain also drop down here. All right, so GABA, GABA, dabba do. Fred Flintstone's relaxed. How about you? So GABA is inhibitory. It can help us with prevention of things that cause excitatory action in the body. So this, if we have too much GABA in the body, we're going to be more relaxed. Not enough, we're going to be more anxious, and we could be more at risk for like things like seizures because there's no inhibitory effect there when we don't have enough GABA. So for Huntington's, they'll have mood swings, personality changes, restless, rapid, jerky movements called coriform, usually in the arms and the face, intellectual impairment because they have a problem with their memory and their judgment because of the issues with the acetylcholine and the GABA. All right. So that's going to be the onset of the symptoms right there. We don't care about diagnosis. Dementia is the next one. All right, with dementia, the cortical function is decreased. So remember, cortical, that's your brain stem with your cognitive skills, your thinking, your judgment, your learning. So we're losing all that and memory. It can also cause problems with confusion, behavioral, and personality changes. So this is a progressive chronic disease. Loss of memory would be affected here, the short term or recent memory, but also confusions about events in long term memory. There's a lot of causes of dementia: vascular disease, infections, toxins, genetic disorders. In Alzheimer's, this is about 50% or more of the dementia. Vascular causes is going to be second. So Alzheimer's is the first for dementia. Vascular is the second cause, most common. We have a progressive loss here of intellectual function. That interferes with work, relationship, and personal hygiene. Personality changes include lack of initiative, repetitive behavior, impairment in judgment, lack of problem solving abilities. So we'll have progressive cortical atrophy. So that means the atrophy area, the cortical area is shrinking in size. That causes dilation of the ventricles, widening of the sulci. Now, the classic hallmark signs you're going to see are those neurofibrillary tangles and plaques, a loss of acetylcholine because of a loss of neurons. The deficit of acetylcholine also will occur here. Plaques will disrupt neuroconduction. They contain fragments from beta amyloid precursor protein, and they're looking at that protein now to see how it really actually affects these people. Signs and symptoms. So this usually goes on over a long period of time, 10 to 20 years. In the early stage, they'll just start to have a memory loss and a lack of concentration. They can't, they have dysfunction in the ability to learn information and to reason. They can have behavioral changes. So we'll see things like irritability, hostility, or mood swings. And then cognitive function is affected here, memory, language skills, problem solving skills, judgment, all poor. They'll have confusion. Activity of daily livings will become hard. And eventually they don't remember certain things, what they're used for. They don't recognize certain things. So in the later stage, they don't recognize their family. They lack awareness in the environment. They may be incontinent, and they usually become not able to function in any sort of way independently. And degenerative changes also are going to occur and affect their motor function here. Vascular dementia, this is usually going to be caused by cerebral vascular disease. It's usually a result of infarctions or mini strokes. Happens in a lot of people over 70, especially those with high blood pressure. These people will have memory loss, inability to manage daily routines, and it can progress. Creutzfeldt-Jacobs disease. Remember, this is from those prions, like in mad cow disease. Okay. Um, sorry, 1 second. All right, so Crutchfield-Jacob, remember that comes from that prion. Mad cow disease, okay? Ingested or transmitted. Sometimes they can get this from blood transfusions. It can be iatrogenic, meaning they got it from some procedure we gave them, or it can be sporadic. So it comes from some outside thing, okay? This has a long incubation period after it's introduced to the brain, and then more abnormal prions would be produced, and then there's a rapid destruction of neurons, and then these plaques and vacuoles start to form, and the neurons will have spongiform encephalopathy. These clients are going to have memory loss, behavioral changes, motor dysfunction, and progressive dementia. And then AIDS dementia. All right, this is common in the later stages of AIDS when the virus starts to invade the brain tissue. And it can be exacerbated by like a candida infection or toxoplasma, or they can develop Hodgkin's lymphoma here, non-Hodgkin's lymphoma when they have AIDS. So that could contribute to this. They'll have a gradual loss of memory, cognitive function, and impaired motor function. So that's going to lead to ataxia, weakness, abnormal reflexes. And in kids with congenital human immunodeficiency virus infection, the brain can also be affected, causing intellectual delays and impairment with motor development. All right, this is the last of it. Okay, mental disorders. All right, this is dysfunction in the areas of behavior or personality. These can be genetic, and it includes things like schizophrenia, delusional disorders, anxiety, panic disorders, mood disorders. Now, with schizophrenia, that's usually a problem with dopamine. Okay, there's changes in the brains of people with schizophrenia, especially in the gray matter and the temporal area in the third and lateral ventricles. Will have abnormal cells in the hippocampus and excessive dopamine secretion. And this causes a decrease in blood flow to those frontal lobes. Now, remember, frontal lobes are responsible for judgment, logical thinking, reasoning. They believe it's genetic, along with brain damage in the fetus caused by some perinatal complication or viral infection in mom during pregnancy. Onset of schizophrenia is usually between the ages of 15 to 25 in men and 25 to 35 in women. And things like going away to college can bring this on. So you might have like a high school football player that was really popular because he was in a really small town. But now he goes someplace like Penn State where there's a million high school football players that are really popular, and he loses his identity. The stress causes this schizophrenia to come out because he already has a predisposition to it. He would have to have that for this to occur. It wouldn't just happen to someone because they went from a small town to Penn State. Symptoms are grouped as either positive or negative. So positive symptoms are going to be things like delusions, bizarre behavior, and negative symptoms are going to be things like flat emotion or lacking emotion, a decrease in their speech. They'll generally have a disorganized thought process. Communication is impaired because of inadequate language skills. They lack the appropriate association of thoughts. So they might use repetition of words or thoughts. Development of new words without a meaning. These are called neologisms, where they say a word that has no meaning. And delusions or false beliefs and ideas are a lot of times present. So I always, when you're talking about delusions or false beliefs and ideas, like when you listen on the radio, you think something's all about you. Or like Trump, he has this delusion that he solved 7 world wars, okay? Those are delusions and false beliefs. When you have a belief about something and it's not real, that's what it is. Depression, this can happen in people, especially if they have chronic illness like diabetes, high blood pressure, cancer. Major depression or unipolar depression usually comes from within us, and it's based on biological factors that include genetic, developmental, or psychosocial stressors. We also have bipolar. This is going to be a problem with also dopamine and serotonin in the brain here. Okay. So this is where they have alternating periods of being really depressed and really high up, really like all this excessive energy that we call mania. This can be genetic, developmental, or psychosocial. All right, so depression is usually a mood disorder and it's decreased activity in excitatory neurotransmitters. So usually we see low numbers in the neurotransmitters norepinephrine and serotonin, and they don't know why. But it could be because of some major trauma, prolonged period or sadness marked by hopelessness. They lack energy or self esteem or motivation. They might be irritable or agitated or have difficulty concentrating. They might have a sleep disorder where they don't sleep enough or they sleep too much, and they may lose their appetite or their libido, which is their sex drive. Come on. All right. So, again, norepinephrine and serotonin are the major neurotransmitters that we look at here. Panic disorder and panic attack, you have to know the differences, okay? So, panic attack are common but don't necessarily lead to a panic disorder. So, this might be you didn't study enough for a test and you come in to take it and you hear people talking in the hallway and all of a sudden you become uncomfortable and you start to develop anxiety, okay? Maybe you even have a little bit of problem breathing, your heart rate gets fast, you start to sweat, okay? But you don't have panic disorder. You just had it that one moment and it doesn't ever happen again, or it could happen again at some point. Panic disorder develops when these panic attacks occur frequently or prolonged, and there's usually a genetic factor identified here. Increase in the discharge of neurons can occur in the temporal lobes. There's abnormalities involving neurotransmitters, norepinephrine, serotonin, and GABA. Remember, GABA, I said, is inhibitory. So GABA dabba do, Fred Flintstone's relaxed. How about you? Fred Flintstone's relaxed because he got lots of GABA. And GABA is inhibitory. When you don't have enough GABA, you're going to be more excited, more anxious, and possibly more fearful. Okay, too much norepinephrine and too much serotonin can also have cause you to be all jacked up or anxious. So signs and symptoms of panic disorder would be episodes of intense fear without provocation. This can last for minutes or hours, and these clients will have palpitations, tachycardia, hyperventilation, sweating sensations, choking, smothering, nausea, all the things you feel before that test. Again, if it doesn't happen all the time without any provocation. So your test provocated yours, okay? Your test caused you to develop that because you didn't study well enough or you're not getting it. But if it happened all the time without anything causing it, then it's going to be more of panic disorder. Sometimes these people might have a fear. So, like someone that has agoraphobia, they know they have to get on a train to go somewhere for an event or for something. Then all of a sudden, this panic disorder comes out. Okay. This intense fear because they know that they got to go do something that they're fearful of. And I have patients that have agoraphobia and they refuse to leave. You can't even get them out. It's very difficult even to get them outside for like just to go for a medical appointment because of their fears. All right. Spinal cord problems, herniated interval disc. This can cause protrusion of the nucleus. A tear in the capsule can suddenly occur or develop gradually because of aging or obesity. Herniation would involve protrusion of the nucleus, and there's a little gelatinous component that's in there. If that leaks fluid or leaks that gel out, okay, that can interfere with nerve conduction and it can be painful. It can cause problems with sensory, motor, or autonomic dysfunction. The most common area that we see this in is usually L4 to L5. But it can also sometimes happen in cervical discs, like between C5 and C7. This can happen from either tissue on the nerve or blood supply or some sort of other damage. Usually we see this associated with motor vehicle or some sort of back injury. Okay, degenerative changes also put you at risk. So you work in a warehouse and you're lifting heavy stuff every day. Age, metabolic changes in the body, obesity can all contribute to this. Also, poor body mechanics, like not following the proper protocol for lifting, turning people, things of that nature. And then herniation is usually caused by either some sort of trauma or some sort of poor body mechanic in general. So maybe you're a weightlifter, you didn't lift those weights right, or you decide to suddenly move something that you don't normally move, and it weighed 40 or 50 pounds, and it put a strain on your body because you didn't follow the proper techniques, or you got rear-ended by somebody in a motor vehicle. Large protrusions can cause bilateral effects because of pressure. Sensory nerve fibers in the dorsal root, lumbosacral herniations cause pain in the lower back, radiating down to both or one leg, and this can lead to things like sciatica nerve pain. You can also develop paresthesias, numbness, tingling. If the compression is extensive, it could lead to muscle weakness or interference with emptying the bladder. I just threw this one on there. You guys have access to this? You have this slide, right? I gave you this one. All right, so this is just telling you what changes you would see in the sympathetic nervous system in response to certain things being released in the body. So just make sure you look at it.
Okay.
And then the last one, which talks about the peripheral nervous system, okay, and how it controls the body and some things that it does. So I would definitely take a good look at these two last slides, okay? That's it.
Yeah.
Questions on anything we went over today? All right, guys. I'll put the recording up as soon as it converts.
Yes. I'm sorry, I do have a question.